It's on? Yeah.
Good afternoon, everybody. Welcome to the Aboriginal ReAct resource overview. My name's Leanne Charlie. I'm from the Little Salmon Carmacks First Nation up in the Yukon, and I work at the Aboriginal Health Strategic Initiatives Office here in Vancouver at VCH. It's my pleasure to welcome you here today. We are broadcasting from the traditional territories of the Coast Salish people, from the Diamond Centre at the UBC Medical Centre at VGH in Vancouver. This is a presentation brought to you by a collaboration between a number of folks, our office, the UBC Learning Circle, and ReAct, the adult protection program here at VCH as well. Just a little housekeeping. I think by the sounds of it, I think all of you have found the mute buttons in your rooms there, so that's good. I'll just let you know that we are recording this to hopefully post on the website and be able to share with others at a later date. So if you have a question, we'll need you to unmute and ask your question. And then Amanda, who I'll introduce in a second, will either repeat that back so it gets on the recording, and then you mute again. Because we can also, it's really cool on this side because we can see all of you on two very large screens in the auditorium. So it's kind of cool. Okay, so it's my pleasure to introduce Amanda Brown. She works for ReAct, the Adult Protection Program. She's going to take us through this resource that is available to you online and in various other forms. Very excited about going over this material and making it as available as we can. And we're looking forward to spending the afternoon with all of you here and all of you out there. So I'll hand it over. Amanda Brown, thanks.
Thank you, Carly, and hello, everybody. It's great to be here, and it's great to see all of you here. It's so much nicer when we can all be in the room together, getting to know each other and share, but with such a big province, I understand that that's really challenging for us to do. So I would like us to take a few minutes at the beginning of our meeting just to check in with all of you and all of us here so that we still can have that personal touch. I think we've got enough people here that we can say who we are and where we're from. So we'll start here in Vancouver, and then I will call on you around the way we see our screens. And at that time, maybe someone can just unmute and you can go around your room and introduce who's there. So that would be really helpful for us. And some of you may also know each other by phone or email, and it might be nice to actually have some eyes and a voice to go with the name as well. So I'm a social worker. As Carly said, my name is Amanda Brown, and I do live on the traditional territories of the Coast Salish people in North Vancouver. And I am first-born Canadian here and with my family, and have been living in Vancouver for about 20 years now. So I really am happy and honored to be here doing this work and learning with you as we go through the process of looking at what are some of the ways that we as a community can work together to keep our elders and our vulnerable adults safe in the communities where they live and with the families they live with. So I just really am happy that we're all here to have this conversation today. So can we go around our room and go to there? And if you just remember to turn your mic on too as you speak. It's on. Oh, hold it down.
Okay, there we go. Hi, everyone. My name is Catherine Berry, and I'm actually the program assistant for the UBC Learning Circle. And so I've been helping to coordinate this session, and I just wanted to come by and say hello in person and to join in this session and just learn more about elder abuse in First Nations communities.
It's off.
Hi, my name's Jennifer Andy. I'm a counselor at the Native Education College in the Family Violence Resource Program there. And I came today too to find out about ReAct. So.
Terrific, welcome. We'll go back to...
Hi, my name is Clara Lau. I work in the facility as the facility liaison. Just recently, I came across a few, elderly abuse cases. So I would like to, refresh my learning. And also in my facility, some First Nation residents. So I would like to know more about their, culture, values, and, services. All right?
Thank you. You have to hold it.
Hi, my name is Tina Alexis. I'm a Langara student. I'm here to expand my knowledge and also to fulfill a seminar requisite. Thanks.
Ruth?
Hello. Oh, hi. Hi, I'm Ruth Kenny. I'm doing my social work practicum at UFV, and this is weird. Okay, sorry. I'm doing my practicum over here at Vancouver Coastal Health, and I'm working closely with Leanne here and Diana Day. So it's good to see you all here, and I look forward to the day. Thanks.
I already introduced myself, but just so everybody knows, Leanne Charlie with the Aboriginal Health Strategic Initiatives Office.
Yes.
Hi, I'm Danielle Jacques. I'm from Health Canada First Nations and Inuit Health Branch. And I'm here to find out about this format so that we can use it with isolated communities in Quebec.
Great, thank you. And I'm just going to recognize Danielle. She is also the funder of these tools through a couple of projects. First Nations Inuit Health Canada became aware of the work that we're doing here in British Columbia in collaboration with the Community Response Networks, who we're going to be talking a lot about today. And through that process, Health Canada did an evaluation of the first edition of the First Nations ReAct manual, and brought together a focus group from representing all parts of Canada. And these folks spent a few days together evaluating the manual and giving some feedback on what would need to be changed in that manual if it were to become relevant for use in all nations across Canada. Once that evaluation was done, the First Nations Inuit Health branch of Health Canada did work with Vancouver Coastal Health to reproduce all of the tools that you're going to see today. So I just really want to acknowledge the funding source here. Okay, and somebody's microphone isn't on mute. I think it might be the Halquayam community.
Hello.
So why don't we get to know you now anyhow? I don't think I said it correctly. Halquayam.
Oh, that's us. Halkaminum.
Thank
Hi.
you. Hi.
We're just checking in from Cowichan Valley in Duncan on Vancouver Island. My name's Helen Dunlop. I'm an Aboriginal liaison nurse with Vancouver Island Health Authority and also with Cowichan First Nations Saywalton Health Centre. And I'm here today to see how we can empower our community members and our staff in dealing with the very underreported elder abuse. Thank you.
Hello. This is, we're just checking in. We're from the Interior Health in Kamloops at the Royal Inland Hospital.
Hi there. We're just going around the province to meet and greet everybody. So what I would like to do is welcome you and ask you to put your microphone on mute, and then we will go around in our screen in the order that we can see them, and we'd like to meet each of you in a few minutes. And the Halkamayam, I'm sorry. The
Is
Cowichan folks. My husband was is from Duncan. I'm there all the time. I should be able to say it, so my apologies. The video camera is pointing right at the chair in front of your camera, so when it zooms in on you, we can't see anything but the chair. So how about we meet the rest of you? Thank you for moving it.
Okay.
And you might want to tilt the camera up a bit. Perfect, yeah.
There we go. Okay. Hi, my name is Angie Gibson. I'm the Elders Program Nurse. We mainly provide home support to elders in their home. And I'll tell you how to say hulkaminum. That's how you say it.
Hulkaminum. Thank you.
Hulkaminum, yes. Okay. And I've had this ReAct binder sitting on my shelf, and I haven't had the time in a day to look at it. So I'm here very interested in the hours that we have to look at it. Thank you.
Hi, good afternoon. My name's Danielle Bain-Smith. I'm Echodene from Fort Nelson First Nation and French Canadian and Métis from the Red River Valley. And I'm a family physician working with Tsewelton Health Center since November. So I'm really looking forward to learning more this afternoon so that I can support the really wonderful work that's already being done here at Cowichan Tribes. Masi Haichka.
Hello, my name is Eileen Ramirez. I'm an LPN for the Elders Program. I work alongside all my coworkers here. I'm new to the Cowichan Tribes Health just as of January, and I'm here to learn all the various ways we can assist our elders.
Great, nice to meet all of you, and welcome. So then I think we'll go around. Okay, so now the top left of our screen, I think, goes back to the interior health folks that came in a few minutes ago.
Hello, my name is Gloria Big Sorrow Horse, and I'm one of the Aboriginal patient navigators for interior health.
And I'm Maggie Duncan. I'm a casual social worker here at Royal London Hospital, working with other adults experiencing abuse.
My name is Carla Ramsey. I'm a social worker in the dialysis unit here at Royal Inland Hospital.
And my name is Mary Ann Boak. I'm the professional practice lead for social work at Royal Inland Hospital.
Awesome.
Hi,
nice
everybody.
To meet you all. Okay, then can we go up to Lionsgate Hospital, please?
Hello, hi. I'm going to we'll start at the end of the table with Jane Osborne to introduce herself. Can you see that far on the end of the table?
Yes, we can.
Okay.
Okay, good. My name is Jane Osborne. I'm the regional mentor for the BC Association of Community Response Networks for North Shore and Sea to Sky Corridor.
Good afternoon. My name is Mitzi Jones. I'm Manager Health Benefits Advocacy and Promotion for the Squamish Nation.
Hi, I'm Melanie Parkinson. I am the Adult Abuse and Neglect Consultant for the North Shore for Vancouver Coastal Health.
Hello, I'm Sheila George, Manager of Home and Community Care for the Squamish Nation.
Hello, I'm Sonia Schneider. I work with Sheila George and Mitzi for the Squamish Nation. I'm the Senior Personal Caregiver.
Welcome, everyone. And I just would like to acknowledge that Jane, representing the Community Response Networks, is, I'm hoping you're going to have a chance to share a little bit about what Community Response Networks do. There is a chapter about CRNs in the book, and the video clips that we show you, the dramatizations, heavily feature the whole concept of coordinating our communities, and the organization that she works with has a provincial scope, and they can provide support and to any of the communities who would like to organize that way. So, and my eyes are getting bad. Lax Galsep? Go. Ruth, could you come up here and help me read out the names of the nations? Because first of all, I can't see them, and second of all, I can't pronounce them.
Hello, you said it fine.
Oh, thank you. No, I do want to stay.
Just introduction, right?
Yes, please.
Okay, we are My name is Mary Lou McKay. I'm CHR for Lac-Alzap. And I have another CHR here to my left, Karen McKay, and we have 7 elders present here with us today, along with some homemakers. So we're here to just listen to the information you have for us. Thank you.
Thank you. And can you tell me where in the province you're actually located?
Okay, we are in the Nass Valley, about 90 miles north of Terrace, BC. And we are under the Nisga'a Valley Health Authority.
Terrific. Thank you. That is very helpful because we need to mention that as well when we talk about designated agencies. So who else do we have? Do you know who these people are down here? Or which one? In the middle, right?
Is it on?
Mm-hmm.
21909. There's
3
Powell River.
Is that
Powell River? Is that Seashelt?
Oh, I know.
Do you hear me?
Seashelt's down there.
Hello, do you hear us?
Yes.
Hi.
Okay, that's Seashelt.
Should we go ahead?
Yes, please, April.
Hi, I'm April Struthers. I'm the regional mentor for the community response, the BC Association for Community Response Networks, and my area is the Sunshine Coast and the north end of Vancouver Island. I also have been involved in the early phases of some of the writing for this ReAct manual. And hello, Danielle. I've been involved in some of the writing for the national projects as well.
I'm Carol Matthews. I'm an older adult mental health nurse on the Sunshine Coast.
And I'm Jane Randall, and I'm an older adult mental health nurse on the Sunshine Coast. Hi, Amanda.
Hi, everybody. We can't see all of you. Your camera is only focusing on really on April and Carol.
She's best. She's the better looking one.
Okay, but we recognize your voice, Jane. Okay, welcome. Now we're going to...
That's Powell River down there, the 20903.
Powell River folks, do you hear us? I see 4 gentlemen in a room, one with them wearing a hat. I don't think they hear us. Are they even here for this conference? They don't look like they're working on our stuff.
Oh. Well, I know they were signed up.
Kingoy. Someone bring the camera there. No. You hear Kingoy?
Hear you.
Everybody say hello. Yeah. Do you hear Kingoy? Sure. Oh, our thing is on, right? Yeah, I just put it on. Oh. You can go.
Powell River, can you hear us? They're working on something else. Okay, so somebody has their mic on and we don't know who that is. Can we go to Stolo Health?
Turn ours off. Turn it over here? Yeah.
There you go. Hey there, Stolo Nation here.
Hello.
Hello, Stolo Nation. Can you hear us?
Yes, we can.
Oh, excellent. Hi there, my name is Jarek Black. I'm the home care nurse here for Stolo Nation.
Hello.
Yes, people are just arguing who's going to introduce themselves next.
I'm Michelle Hobeck, and I'm the administrative assistant for our Stoll Elders Lodge of Assisted Living.
Tracy McLaren, activity worker at Stoll Elders Lodge.
I'm Jens Malloway, and I coordinate the ASSERT team for Stella Nation Health Services, primarily in crisis response, particularly regarding suicide. These are 2 of my community reps, Frida and Glenn. Thanks.
Hello and welcome. So who have we missed? Nisga'a Valley Health? Or did we talk to them?
Oh, we didn't?
No.
Oh,
no.
That was the...
Nisga'a Valley Health, can you hear us?
Yep. Could you hear us?
We can. Welcome.
There's, you want to introduce yourself, Barb?
Barb Canoe. I'm a homemaker for different families for 14 years at our care. And I look after our elders.
Faith Tate, Nisqualissim's Government Justice Department. Millie Percival, Nisqualissim's Government Victim Services.
Jackie Adams, Alcohol and Drug and Community Wellness Counselor for New Orleans.
Judy Rice, homemaker for the Black Diamond.
Thank you.
Thank you and welcome, Niska. Your camera is only focusing on a couple of you, so we heard lots of voices, and those last folks that introduced themselves were kind of far from the microphone, so it may be that if you want to have questions or discussions later, we'll have to have someone who's close to the mic repeat them. So now, have we missed anybody? Down the bottom left corner.
Squamish.
Oh, Squamish.
Squamish Hospital?
Squamish Hospital?
Yeah, she's waving. Hi.
Hi. Can you hear us?
Yes.
Yes. Christine Baker, Squamish Nation. Joyce Thavarge and Quatqua First Nation.
Hello
Darcy.
and welcome. Oh, sorry. Is there somebody else in there?
No, I just said Darcy.
Oh, Darcy. Oh, so you've had a long drive to get there today?
Oh, yes.
From Darcy? You're not in Darcy, are you right now? You're in Squamish?
No, I'm in Squamish.
Great. Now, have we missed anybody? Okay,
Yeah.
so... Oh, sorry, who have we
Hello?
missed?
Hi.
King
We're
Boy.
from the...
Oh.
Hello?
Hello?
Hi.
Is that
The Redstone Clinic in Alexis Creek First Nations.
Alexis Creek. Hi, Redstone Clinic. We
Hi.
can't see you. We can hear you, but we can't see you.
Yeah, we're having trouble with our camera. So I tried to get it to work, but it doesn't seem to be working. But we can see you and everything.
Okay, so tell us who's there.
Okay, so I'm Deb Johnson. I'm the community health nurse in charge of the clinic. And we have
Darlene Baptiste, NADAP worker. Agnes Case, CHR worker.
Marcia Harry, home and community care. That's it.
Terrific. Well, I'm sorry we can't see you, but I'm glad you can see us, and I'm glad that you're here. So welcome, everybody.
We have King Cole here. We have King Cole here.
Yeah. Yes.
Are we out in
Or
there?
we can see you now. Oh, no, that was Squamish.
Can you see us?
Can you... Hello, we can hear a lot of you, but I missed who you are or where you're from.
Okay, John Moore, Board of Directors for Nisku Valley Health Authority, situated in Kingoly.
Say Out Health Center, Vancouver Island. Oh.
Hello, Sewell. Are you all together?
Say Out?
No, it's ours. It's on Vancouver Island. Kingoly's on the Nass River. Can you hear?
I can hear you. Thank you. Is there anybody we've missed now?
Yeah. Did you get us? We're some nurses sitting here at the Say Out Health Center.
We see somebody's arm, and we can hear you.
Okay, and we can't see very much on our TV screen either. So.
Oh, sorry. This is very challenging.
We see the front page of the binder, so that's what's important, right?
Yeah. That's the most important thing.
Yeah. Okay, she can hear.
Awesome. So what we'll be doing now, I just want to thank you all. I know it's a bit painstaking to go through introductions this way, and thank you, Ruth, for coming up. I wasn't even sure all who said they were coming to this party, so so it's really nice to know who's come now that we're all together. So my understanding of what we're here to do today, thank you, Ruth, is to talk, and many of you have mentioned this, to talk about the First Nations ReAct manual and tools, and learn about how we can use those to help us in creating our responses to people that we're concerned about in the First Nations communities who are experiencing harm through abuse, neglect, or self-neglect. Now, my understanding also is that you were invited to come till 5. I think that's a long time for any of you to sit in those small rooms with a camera pointing at you. So by a show of hands, who would like us to try to wrap up by 4:30?
That would be nice.
Or earlier.
Or earlier, okay. Does anybody really feel strongly that they want to be here right till 5 to get every last little bit of knowledge out of my head? Nobody does. We can empty my head of all knowledge by 4:30, so that's really great. So that's what we're here to do. We've got some interactive, we have a lot of videos, so you're not going to actually see me doing a whole lot of talking. The video, well, we are going to see a whole lot of talking, but the videos actually say way more in dramatization than what I can do by telling you about this. The purpose of the ReAct manual is to bring to the hands of healthcare workers, social workers, home and community care staff, anybody who's working with elders or vulnerable populations. It's to bring into their fingertips reference tools, manuals, processes, things that they can use when they're trying to create a response to concerns or situations of abuse or neglect or self-neglect. They also talk a lot about community coordination. And when we talk about community coordination and community response networks, we're looking at things that can do prevention, raise awareness, create a network of safety and support, and create a culture of safety and support before the abuse happens to the elder. So that's really important for us to have, that these manuals really try to look at both of those parts, the actual clinical response, that like many of you are healthcare workers and nurses already, that you may actually have a time when you need to reference how do I conduct this interview, what are the legislative tools that I need to do to intervene with a specific situation. But communities really need to work together to know how to create that culture of safety in the first place. So we're going to be looking at both of those parts, and these tools have a lot of that embedded all in them. So I want to tell you before I carry on and forget, the First Nations ReAct manual, the original BC edition, as well as the national edition, are available online to all of you. You can just go to, and I'm going to, if you have a pen, you want to write this down, it's www.vch, as in Vancouver Coastal Health, .react, REACT.ca. So that they're always there. Now they have been sent out to, the British Columbia version has been sent out to all of the First Nations reserve communities, health centers, contacts that we have in BC that are connected, that are a part of VCH's catchment area. And then the Health Canada First Nations Inuit Health Branch has sent them out to all of the regions. And Danielle, do you want to just say how they got distributed?
They were sent out to all the home and community care programs through Elizabeth Pierce. Our regional coordinator would have sent them out quite a while back, actually.
Okay, so most of your communities should have them. You probably would have got a printed copy, and you would have gotten a little USB stick. Now, the way I'm going to show you the tools today is going to be just going through it on the USB stick. So if you get that USB and you plug it into your computer, you'll get all the interactivity that we're seeing. So I'm not showing you a PowerPoint presentation. What I'm showing you is the actual manual and how you can use it and work through the tools yourself. Because it is very interactive and the videos are embedded right on it. If you don't have the USB and you don't have the print manual, you can go to my website and you can just download it. Very easy to download. The print version, I think you probably will have to watch the videos from the website though, so you will need an internet connection if you're looking at it from the website. So www.vchreact.ca is how you access them. We don't have a lot of extra copies. We don't have any extra copies of the First Nations tools, but printed versions. But we're happy if we can to send out a USB if you're having problems getting the information. Does somebody have a question?
Somebody left.
So somebody's mic just became unmuted. If we can ask you to remute unless you have a question. And probably it's a good thing if you do want to interrupt with a question, we'll hear your microphone unmuting, but maybe give me a wave as well so that I know who it is that's talking. Thanks. So without any further ado, I think what we need to do is just jump right into the manuals. So you're not going to be able to read all this, and I'm not expecting you to. I'm going to enlarge the screen when it comes to the videos, but what I just want to do is kind of show you the general layout of how you can use these tools if you need them. Obviously, it starts with a table of contents and gives an overview of how the manual is, who the intended audience is and how you can use the tools. So it tells you how to print, that sort of thing. I'd like to pause here just a little bit on the definitions because it is important that we do know who we're talking about and what we mean when we're talking about abuse, neglect, and self-neglect. Because, that in itself, if we start using language like elder abuse, what does that mean to you? For some people, that means the children haven't called in weeks. And the elder is at home alone and lonely and worrying, and they consider that abuse or neglect. For other people, it's only ever, used in terms of violence. So it can be, a whole continuum of things. So we've had to put some definitions around when we're talking about what we're meaning by intervening in abuse and neglect situations. We've had to define it as being the deliberate mistreatment of an adult that causes or is likely to cause physical, mental, or emotional harm or damage to or loss of assets. So it is really important that when we use language like abuse, that we are talking about it being a deliberate causing of harm to somebody. Also, just to talk about the term elder, we recognize that, all of our cultures and our nations are so diverse and that we have different ways of achieving the status of elder. Sometimes it's defined by age, sometimes it's defined by a position of prestige or having achieved a certain expertise in a particular area. I've been in rooms where some 30-year-olds are considered to be elders because they are, the teacher and the mentor of a certain either a medicine or healing or some sort of practice. And other times I've been in the room where there's been a extremely aged older gentleman in the room, and I asked if there was an elder who could, comment on something, and they all looked around the room and said there was no elder there. So that particular nation did not consider age being the thing that would achieve the definition of elder. So I'm not going to make any kinds of presumptions about what an elder is to you, or whether you are one or whether you're not. And that's really not the point, and I don't want us to get kind of lost in that definition. I want us to be thinking about how we create our response to people who may be older and vulnerable because of certain conditions. So, or they may be younger, but may be vulnerable to abuse or neglect because of certain things. So I'm mostly going to use the language of vulnerable adult when we talk about how we intervene with abuse, neglect, or self-neglect, but that, please don't take that as meaning I'm not recognizing elders. I just want us to consider all people and where they have their strengths and where they have their vulnerabilities. And that's really what has to guide our practice when we come to the point of needing to intervene or wanting to have conversations with them about their safety. Does anybody have anything they really want to say about that before we move on?
I just wanted to let you know that Kincolas has been disconnected. We don't know why.
Oh. Do we have anybody who can look at that technically, Ruth? We'll see if we can connect with our folks here. So, sorry, which community got disconnected?
Kincolas.
Thank you for letting us know.
Yeah, it's Nisga'a Valley Health, Kincolas.
Nisga'a Valley Health, Kincolas. Okay, we'll do what we can to see if we can get them reconnected from our end.
Thank you.
Thank you. So again, when I talked about who the target population is, our audience for these tools, I talk about healthcare workers, it may be home support workers, could be your community health rep, you know, basically where it could be the social worker who isn't really health. And I don't want us to get so caught up with, oh, well, I'm not, you know, a community health and human service worker, so therefore this doesn't apply to me. We're trying to capture, you know, broad categories of people who are working with older adults in their communities or who are working with adults who are compromised because of their health for some reason. We're going to talk a little bit about designated responders and designated agencies. And then we also put the definition of neglect up here, which does involve the failure to provide necessary care, assistance, guidance, and attention, which causes the person or is likely to cause the person physical and emotional harm. Or neglect can also be neglect of finances and assets, you know, not paying your rent and then becoming evicted because of that is a neglect of your finances. We've heard somebody just come on. Kincola's back. Welcome back. And we can see Redstone now too. Your camera's on. I think it's also important that we talk about self-neglect and we understand that there is also a definition of self-neglect. I think probably all of you have been into homes or communities or places where you see somebody living in a situation and you wonder, how is that person safe there? Do they have heat? Do they have running water? Do they have access to telephones? Are they living in grossly unsanitary conditions? These are all really important things that we think about. And if we understand and become aware of the definitions of things like self-neglect, we may also be able to start finding ways to respond to that differently. So those are just basically the definitions. The other thing that's important for us to be aware of when we look at these tools is they are grounded in the values, principles, and presumptions of the Adult Guardianship Act, that is British Columbia's legislation for guiding the work of adult protection. And we've used it because they are sort of universally accepted values and principles throughout Canada. So they were applicable to pretty much everywhere. First of all, self-determination and choice. What we really want elders, vulnerable adults, and the healthcare and community and social service folks that are responding to situations of elder abuse is that we want them to not go in and think they have to rescue everybody from those conditions that we talked about. What we do want people to always hold in very high regard and to guide their practice is that self-determination and choice is very important to allow people to live in the conditions that they choose to live in with the people that they're having a relationship with, even if those aren't the way that you would choose to live, even if you think that person may be unsafe. What we do is we need to honor someone's rights to make their own choices and provide as much safety as we can. If they're not capable of making that decision, things change and we do have to intervene differently. But even in those situations, we will try to find out what their previous values, wishes, and beliefs were, how they lived their life. So we will try to honor that even when they're no longer able to have the judgment around that, and still find a way to work with them to keep them safe. Most effective but least intrusive support is the second principle that these aren't in a hierarchy, but is a very important principle, that we will say that adults have the right to receive the most effective intervention that is also the least intrusive. And that striking that balance is really challenging. It may be very effective for us to get a restraining order to get, Sonny Boy out of the house if he's being really abusive to his mom. That's a very effective, from my perspective, way of making her safe, but it's not probably the least intrusive if she wants to still have a relationship with him. So we have to always look at, balancing effective interventions with being least intrusive. Another way of making people very safe very quickly is to take them out of the environment that they're in and take them to, say, like a long-term care facility or a hospital. We can, probably be very effective at making them safe in those circumstances. But again, it's not always the least intrusive way of intervening. Hi, I'm here to help you, and then I haul you into an ambulance and take you away from your home. So sometimes that may happen, but that's not really, that's really our last resort. So court is also one of our last resort. Going to court, we do have some tools in this legislation in British Columbia that certain agencies can use to apply to court to get things like restraining orders, to gain access to somebody if they are not letting us to come in, if we want to get supports and services and assistance in place to a person who is resistant or their family member is saying, no, we don't want you here, but we feel it's really important to get, say, the home care nurse in. We can get things like a court order to say, you need to make it so that we can come in and provide the necessary care. So there are ways of getting access and interventions into people who are vulnerable using things like court and other somewhat intrusive measures, but we will always do that as a last resort. So as I scroll down through this manual, you'll see that we get to things like this, pictures in the middle of a page. And this is where the interactivity happens. Pretty much everything that I'm saying to you, we're going to see in these videos as well. And so I'll just set this up for you. In the British Columbia version of the manual and dramatizations that we had, the dramatizations, the case studies were little cartoon animated characters. So you may have seen those, and those are on our website as well. I do want to just give a cautionary note here that some of the videos, not in this first one, but the next two that we see, do depict situations of elder abuse, and they can be a bit disturbing to watch. So just want to let you know if there's anybody who's going to feeling a little bit uncomfortable with that you may want to take care, or feel free to leave the room while they're on. They're not completely horrific or graphic, and this sets up the whole notion of community response networks. So I'm just going to let you watch it. There we go.
When adults and elders are abused or neglected, it is difficult to know when to step in and offer help. However, across all of Canada, in every province and territory, there are agencies in place to support and assist abused or neglected adults, and laws that address most situations that involve abused or neglected adults and elders. Sometimes it can be hard to define abuse, neglect, or self-neglect. Other times it can be hard to know when an elder wants or needs help, or even to know if they can get it on their own. It is important to follow certain principles that will guide the actions and promote and provide support and assistance to those in need. Well, there are some legal tools that certain agencies, which we call designated agencies, can access for more formal interventions. There is a lot that communities can do to make it safer for their elders and other vulnerable adults. A coordinated community response involves anyone who cares about stopping abuse or neglect. This can be called a community response network. Your community may already have one. If not, perhaps it is time to create one.
Hi, I'm a community health worker. I work in the band office, and it's my job to liaise between patients, families, the community, and healthcare providers. I ensure that patients and families understand their conditions and treatment and are receiving appropriate care. I'm also a member of the Community Response Network, and she is our Community Response Network coordinator.
I'm glad you can join us. Abuse and neglect are complex issues that require the experience and the concern of many people and organizations to be effectively addressed.
A community response network is a group of people from community organizations and other concerned community members who work together to create a coordinated response to adult abuse and neglect. Often, community response network members are employed by service agencies such as the band's health services, the local church, the police or emergency services personnel, and the restorative justice program. Sometimes, members are volunteers who work with elders, and we even have elders who come to our meetings.
We develop relationships, agreements, and protocols among members about how we will respond as a community when an adult needs our help. Our goal is to prevent abuse from happening in the first place.
I am an emergency health services staff member. Unfortunately, many adults wait until they're seriously physically injured before asking for help from an abusive situation. Abusive behavior is not restricted to one family or community.
As hard as it is to ask for help from family, friends, or community members, the sooner we start talking about abuse or suspected abuse, the easier it will be to break the silence and prevent adult abuse and neglect.
I'm the social worker, and I work for the designated agency. I'm part-time at the hospital and part-time in the community. Depending on where you live, designated agency representatives may work for a local regional health authority or some other adult protection or social services agency. In general terms, we all assume that adults can take care of themselves and seek help if they need it. But in some cases, adults cannot seek help because they're more vulnerable. This may be due to a physical restraint, physical handicap, disease, illness, injury, or other condition that may limit their ability to make their own decisions. Things like depression, dementia, or alcohol and drug use can also make an elder more vulnerable to abuse.
If a designated agency receives a report about an adult, that agency has a responsibility to look into the situation and coordinate a response.
Designated agencies work with the adult to give the kind of support he or she wants and needs. This may include informal support from family, friends, and advocates.
If a situation cannot be resolved informally, is urgent or dangerous, your province's laws that govern adult guardianship or adult protection may give designated agencies additional tools or authority to help protect adults. Also, don't forget that many types of abuse and neglect are crimes and should be reported to the police. The Criminal Code of Canada is applicable in all provinces and territories.
That's right. These tools might include giving an agency the legal authority to get in to see an adult when access has been denied.
Short and longer term restraining orders to keep alleged abusers away.
And like she said, designated agencies should report suspected criminal offenses against vulnerable adults to the police.
Okay, so just as I'm getting back to the manual here, I'll just note and recognize the videographer and director and the graphic artist who put all these tools together. His name is Michael Auger, and he works with or owns and operates in digital media, and I think they did a great job. And one of the things that I just also want to acknowledge is that everybody who worked on all the dramatizations, right from the music and the artwork, the actors, were all First Nations people themselves, or Métis, and they really put their heart and souls into these dramatizations because they really saw it as a worthwhile project. So, you know, other than me giving some script context and development of the stories, I wasn't involved with these at all. So I see them as authentic as we can get them. So as we move on in the manual, from what you just heard in that clip, is we're talking about community response networks and you're talking about designated agencies. And from our introduction this afternoon, all of you are basically the people we've just met, right, in that video. We've heard about community health workers, people who work in the hospitals, for the health authorities, social workers, coordinators of the community response network. So when I look at the screen here and I see all the people that have come to today's session, I really see the fabric of a community response network. Whether you know it or not, I think you folks are all the right people to form that coordinated response in your communities because you're here, you care about this issue, and you see yourself as having a role to play. So that's really important. So then when we get talking about, well, what are the roles to play, we've talked about things like designated responders and designated agencies. So because we're doing this in British Columbia, I can feel pretty confident to share with you, if you don't know, who your designated agencies are and where in British Columbia that context comes from. So before I get into those definitions, I just want to tell you about why this map is on the page, because this is a national tool. What we quickly learned in the evaluation is that the laws about designated agency and who are the formal responders in British Columbia are completely different than the laws and the people who are designated agencies and responders in Quebec. So, and everywhere in between, they have different laws that guide this work, different resources, different agencies. So these maps that you'll see throughout the manual will get you the opportunity to go into that jurisdiction and find those resources. So because we're talking about British Columbia, it'll take you to this page where we're talking about the adult guardianship legislation, so the adult protection legislation, substitute decision making, and then it gives you all kinds of links of where you can access that. So as workers in the community, especially because we've got people from all over the province right now, you may not have the same resources in Nisga'a that you have down here in Vancouver. And I'm particularly interested in our partners that are here from Nisga'a because I'm not sure what your connection is with your local designated agency. So hopefully we'll be able to talk about that. So that's just how those maps work. And then what you can do is go back to the chapter you were at and toggle back to where you were at in the manual. So that's just the interactivity of these tools. So when you're looking at them, that's how you can use them. Obviously, when you're looking at it in a printed version on a manual, you can't toggle back and forth, but all those resource pages are at the back of your manual if you have a print-only version. So they're there. It's just not as fun to use them if you just have to flip to the back of your book rather than being able to click on a map. So designated agencies and designated responders. I think that is really important for us to take a bit of time to talk about who they are and who plays what role. So in British Columbia, we have the Adult Guardianship Act, and that Adult Guardianship Act sets out, I'm trying to find the right spot in here, it's designated responders, sets out the laws that say who are the agencies that have the mandate and the responsibility to receive reports and conduct investigations into situations of abuse, neglect, and self-neglect of adults that are considered vulnerable according to the criteria in that act. And vulnerable, according to the British Columbia legislation, is if the adult is unable to seek support and assistance because of a physical restraint, a mobility impairment, or some other illness, disease, or condition that prevents them from seeking support and assistance specific to that abuse. So in British Columbia, the designated agencies are your 5 regional health authorities, as well as Providence Healthcare. And for adults who have developmental disabilities, the designated agency is Community Living BC. So that is the general structure of how the legislation works. But how are those designated agencies present in your communities is one of the things that I think will be different in all of your communities, right? So in urban areas, there may be a health center and a liaison with the health authority because of the long-term care and home care nursing program. In other areas, there's very little interaction with the designated agency. Does that seem fair? Most of you, agree that it's some areas do it one way and other areas do it another way? So as long as you know that the people who have the authority and can access tools to come in and protect or a vulnerable adult, even if they don't want it, the authority comes from the Adult Guardianship Act, and that has to be from an agency designated. Was there somebody with a question? Oh, Stolo left and came back? Okay, so that's one of the reasons why we talk about community response networks so much, because that's really what we see one of the roles of a community response network is to connect with the designated agencies, both the CLBC or the health authority one, as well as the community partners, all of the organizations. It may be the local Meals on Wheels, it may be the communities of faith, it may be the victim services worker or the local police, or the RCMP, depending on who you have in your neighborhood. And all of these people have roles to play in making our vulnerable adults safe and building safer communities. So designated agencies and designated responders usually are the ones that have that mandatory response. So even if, say for example, we'll take our local community here. So I work in Vancouver. Tsleil-Waututh Nation has their own health center. They have their own social workers, their own elders workers. I'm not generally in Tsleil-Waututh Nation providing support and services. But if there's a situation where we need to get into a home at Tsleil-Waututh because there's somebody who we're concerned about, I would be invited by one of the staff at Tsleil-Waututh to come and help them in their response. Because if, say, for example, the elders support worker couldn't get into the home and there's somebody in there who we're concerned about, that elder support worker doesn't have probably, first of all, the training, second of all, the legal authority to enter into a home uninvited and against the will of the people in there. And the designated agency may be able to get that authority using the Adult Guardianship Act. So we have some access to some tools that we can use, but that's why it's so important for us to make sure we coordinate how we use those tools and authorities so that we're not, you're not going to want Amanda, driving up onto the reserve and pounding down the house of somebody because I think Auntie's in there and she's, not had breakfast today and I need to make sure she has food, right? I mean, there has to be there has to be some real partnering on how we interact and do those interventions. So the coordinated community response helps to sort out who does what. And if you do invite me into your community, what will I be doing? How will I be approaching it? What are the values and principles that will guide my interventions? And that all comes from, in being informed by these tools and how we work together. So these manuals have lots of places for you to customize your own materials in your communities. So if you have an area where you don't have a really advanced system of responding to abuse or neglect, there's some tools in here that you can adapt to be like your own. One of these is a response flow chart. Now, I'm not going to go through the whole chart with you, but basically what it does is puts it all into a picture form. What are some of the indicators that you need to watch out for with abuse, and then follow a process down on meeting the adult, trying to determine if they are in fact experiencing abuse or neglect, trying to determine if they are in fact vulnerable. If they're not vulnerable, they're capable, competent adults like all of us in the room, but they're still experiencing some sort of harm. There's lots of things you can do there as well, but that wouldn't meet the criteria of the Adult Guardianship Act. So that's where you have a split here. You'd go one way for the capable adults who aren't vulnerable, and you go a different direction for those adults who are more vulnerable or compromised, and then you walk down this path where you want to look into it more and bring more people in to help work towards getting just the right amount of support and assistance to that adult. So this is it kind of in a picture. And when I said you can customize the tools, a lot of nations say, well, DH's logo on it, we're not going to use it. So what we did is we've left a whole blank spot down here, and on the USB you have something that looks like this. You get little folders that say customize your materials, and you can click onto that and you get your flow chart in a format that's not locked down. And all you have to do, I should have tested this first, they're loading another version of Word. You can click here and put your own symbol, your nation's identity, branding, logo, whatever you have, you can put it on there. So if you wanted to have something like this in your local health center for your own staff to follow, you could put your own health center's identity on it. And so we're not, hung up on the whole copyright. The rest of the material is kind of locked down in terms of content, but you can certainly customize it to meet your organization's needs. So I'll just go back to where we were in the manual. So those are some of the tools that you have. Now, if you, as a healthcare or human service worker, you are never going to sit and read this manual all the way through, right? But if you want to have it, someone said, I loved it, someone said, we've got the manual, it's been sitting on our desk and don't really know what to do with it or haven't had a chance to look at it yet. Because I think that's the reality, is we get these things and we're all busy, and who has time to look at them? So we can put into the manual things that we really want our staff to know about our organizations if they do go and pull that manual. So if you folks in the Duncan area have some local protocols, or you've got, a block watch program, or somewhere that, a women's center that is very involved in this area, you can cut and paste into the manual the things specific to your community. And we really want these to be customized to your nations and used in whatever way fits your organization. Did I miss? I'm not sure. I might have missed. There's a spot where you can actually cut and paste into the manual your own protocols and policies. So, for example, we have in Vancouver Coastal Health a respectful workplace policy. We have some rules and some policies around home visiting and checking in with your local center. And some sites we don't allow our staff to go alone if we think that there's some risk. So we could cut and paste those into this manual. So if your new worker just went and grabbed that manual, they would get your own specific information as well. So that's how we would like to see you do this. Now, the other thing that we felt was really important, and we were given the guidance from the national focus group, was that people need to know if you're from a more formal agency and you're coming into a community because there's a concern about one of your vulnerable adults or your elders in that community, how do we go in? And how do we make decisions and choices carefully about what that person needs or what their experience is or whether it's abuse to them or not? So part of this dialogue, there's just a dialogue between a social worker, Colleen Stewart, and Dr. Sherry Lynn Kelly, who's worked a lot in the field of domestic violence, talking about some of that. So I'm just going to show you that clip quickly.
My name is Colleen Stewart, and I'm a social work case manager with Vancouver Coastal Health.
And I'm Sherilyn Callahoo. I'm a member of the Michelle Band.
What is the impact of violence and abuse on First Nations families and communities, especially where Native elder women are concerned?
I think there are two kinds of violence. There is a link between internalized racism, which is an inheritance of possibly attending on their own, residential school or not. And there is an intergenerational legacy of violence and abuse. I remember an elderly Aboriginal woman. She asked me once, she said, go and buy me those Centrum vitamins. And she gave me all this money. And even I looked at it and went, this is too much for vitamins. So I bring it back and and I say, here's the bill, here's your change. She goes, I never got any change before. She looked at the bill and she says to me, were they on sale? Well, her niece had been going to buy them and taking the whole thing. That's abuse. And it's those tiny little things. We think of abuse as domestic abuse, which has become very Hollywood. And where do those elderly women have a voice? Because they haven't been taught, or to speak up to authority, and that goes back to residential school. To speak up means violence. You're going to get hit. We have to start teaching how people can actually ask those questions that have become so commonplace now. Are you safe? Are you being abused? Helping older women to self-identify situations of abuse and say, no, you can't do that. It's not right. And feeling the safety of being able to say that. How are we going to change generations if we don't learn how to say it for ourselves and tell our own people when what you're doing to me is wrong? You can't do that.
And I think what I hear when you say that is that Native elder women especially, because of their experience in residential school and other settings, abuse settings, is that they don't have a voice.
Yeah.
And if they try to have a voice, in the past it meant being punished.
Yeah.
And so how do you tell somebody that it's okay? Now you do have a voice and it's okay, nobody's going to punish you. That's a big it's a big transition to make.
Self-government begins when you get up in the morning, when you wake up in the morning, and whether or not you decide to get out of bed, that is self-government. But we have sustained centuries of not being nurtured, taught, role modeled, coached for that level of self-government, for that level of autonomy. So I understand that woman's fear, because with her mother or her grandmother before her, or residential school, the priest telling her to stay in an abusive marriage. I mean, we have all kinds of agents that did not teach her how to be an autonomous woman, willing to put up a roadblock once in a while because it's scary, because something might happen to me. Because nobody told me it's okay to be aggressive, assertive. Are these women's words? Loud. To say no, 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 no. So unless we have role models in our community or coaches who can assess the ability of an individual, can you think in a day where a health professional assists us to be autonomous and says, you know what? Let me help you be autonomous. Let me help you be self-governing. No, what do they usually say? They say, well, if you're going to have self-government, you better tell me what it is first. I'm waiting. Tell me.
I mean, just that comment is just, it's just making me think, you know, when you talk about autonomy, being the moment that you decide to get out of bed, when I hear the word being autonomous, it's really loving yourself, and it's something that we don't know how to do. And so then if you have a healthcare professional saying to you, tell me what self-government is, it's loving yourself and being able to take that step of making good choices for yourself. Yeah. But that's so easy to say and so hard to live.
Yeah. Especially when we haven't had generations of somebody standing beside us saying however it needs to be heard. And that kind of mentorship. Where are we going to get that? From a whole bunch of priests and nuns, MLAs, MPs, specialists? Are there going to be self-government specialists who come around to help us now and say, here's 5 ways to be self-governing? No. I think the guardianship act is really going to be important. It's hard enough to be fully capable. And to wake up some mornings and go, I've got to be really courageous. I have to be self-governing today. I think it's important that we are also not so afraid to say to each other, are you safe? That's the question. That is the question that people will most often answer. Are you safe? Because it makes you think. Are you safe today? And if they say yes, they are, then you ask tomorrow, are you safe today? Because every day is an opportunity for this kind of exploitation.
And it just makes me think that the roots go very deep.
Yeah.
You know, because it can start, like you say, at 14 or 15, and that person in 50 or 60 or 70 years is now they're a native elder woman who, you know, somehow through life has not been given that opportunity to have a voice, that opportunity to have the autonomy.
Okay, so that was a little clip that was done during a day of working on the first BC edition of the tools. And I think Dr. Kelly was being very provocative with us in many ways when she was saying, you know, likening abuse and neglect of older adults to this whole notion of self-governance. But I think some of her points are really important about every day is a different day. And what we in healthcare often lose sight of is where someone may have said to us last week, no, I'm fine, I don't want you. Next week is a different week. And I think it's allowing people to find their own time and space to come forward and share, disclose, ask for help if they want help. And I see in my practice a lot of times people will say, well, you know, I went out there, I met with a person, she's denying that she's being abused, she says she's fine, and we know she's being abused, but, you know, what can we do? And there's that whole sense of, because the person said no, there's nothing else I can do. And then we get this feeling of powerlessness ourselves as healthcare workers and social workers and people who care, and community members who care about somebody. And it really hurts us to watch somebody be harmed and not know how we can intervene. And then we start accepting some of the behaviors and tolerating behaviors which we think really are actually not acceptable, because we don't know how to intervene and to be able to keep going back at different times in different ways, offering different types of support. So this chapter on overcoming a legacy, I think, is a really important one for people going into communities from which they weren't born or raised. And I've heard a lot of you today saying where you're living and working now, but that's not where you are from or where your people have come from. So what we do know, and what you have been telling me, is that not all our nations will do things in the same way. And it's important that our workers know that. And so we want them to understand some of the things about cultural diversity, cultural engagement, understanding this legacy of silence and abuse that a lot of the colonization has done, and Indian residential schools have brought into communities for many, many, many generations. And, it's not necessarily okay for, the trained nurse who's, living in this, community and feels very strongly that she needs to, provide healthcare treatment to people and cure them and fix them and treat them. And, quite often I hear that frustration of, well, why can't she just tell him he has to leave? Or why can't he just say, no, I'm not going to drink while I'm taking these pills? Or, why don't these older adults just tell their children to leave, or their neighbors, or whoever it is that's harming them? And be kind of stronger or more vocal about that. And I think we need to put our minds to, where the community is at, where this specific community is at, where they've come through, what they've been through, what that individual family within that community, what their story is. And check out our own biases and thoughts and ways of being, because the support that we're offering can be more harmful if we're not careful. And we don't want to go in and create more trauma for the person or their community. You don't want to go in a way that is so disrespectful to the family or the community and the values and how they're working towards keeping people safe. And kind of blow your relationship with them, and then you may never get invited back again. And I will hear that, where some communities will say, well, yeah, I called the social worker, or I called the police officer, or I called the whomever once, and, he or she came in and they screwed it all up and they made it worse, and then they just left, and now we're still dealing with this elder who doesn't have anybody to look after them. And we don't want to create more chaos. So this chapter is a really important one for staff and community workers going in to work around either building the community response or and developing how we will work together when there is an individual response that we need to do. And again, I see the community response networks as being really important in that. When we do go into communities, we think it's really important to follow some of these values that these were and guidelines that were developed in the Interior Health, working, from what I understand, a collaboration of all the First Nations communities in Interior Health, where they really encourage their health staff to follow the principles of cross-cultural engagement. And so we've borrowed with permission from Interior Health some of those, and we included those because we thought it was a really good piece of work to guide staff going into communities. So I think that's really an important piece if you are from more of a formal agency who are going into a First Nations community. Just so you know, I was asked to give us a break at 2:30. Is that okay? So can you hang in for another 8 minutes with me, and then we'll take about a 15-minute break. So the other thing that's really important for us to be aware of and to discuss when we're talking about abuse, neglect, and self-neglect, which very often means violence, is that we have to look at the safety of the staff that we're sending in, the community around the person, and the safety of the vulnerable adult as well. So I think it's just really important because it can be very frightening to a nurse or a social worker or a physician or, a healthcare worker whose primary reason for being in that older adult's life is to look after the healthcare needs, or for an elders worker or whoever it is that's going into the home of somebody. And we're going to see this in one of the videos later, where there is some risk to the individual. And in fact, I heard on the news last night there was a shooting here in, was it Abbotsford? Does anybody know? I just, on the news this morning, again, it was, oh no, it wasn't. It was in another part of Canada. It was 2 police officers. It might have been in Quebec. 2 police officers were shot. One was killed. The other one was injured, responding to a domestic call, a domestic violence call, right? So police will tell you that all the time, that some of those are the most violent calls that they will go into because you're in the heat of the moment, the impassioned, violent acts that are happening. And it's, people are maybe in that moment in time not of their right mind and, may choose to have a violent out rather than be having the system interfere with them. And there are times when we start, in a very non-intrusive way, asking the suspected abuser about what's going on, start having the conversation with the older adult themselves, and that could, in fact, create some anxiety, create it so that the person who's the abuser feels threatened and the violence might escalate or the abuse might escalate. Or you may say or do things that when you leave, the person who's more vulnerable may be punished for, that busybody social worker coming for an interview asking all these difficult questions. So I don't really want people just to think that, reading through this manual is enough training to go into a situation where you could actually, by being there and asking questions, make the situation worse for the person who's experiencing the harm, or put yourself at risk, or put anybody else at risk. Also, just one of the things we need to note too is the people who make the report of abuse to the designated agency are often very concerned that they will, if anybody finds out that it was them talking to us, that the person will come after them. So if you think of siblings and, I've had many times where a daughter will say, if my brother found out that I had even spoken to you, he could come and kill me. My husband and him have already had fights. He knows where I live. I've got young children. If he thinks that I've been ratting on him, he's just gotten out of jail. We know he's got weapons. He's been violent in the past. All of those things, people are very afraid to say anything for a number of different reasons, but sometimes it's because they're afraid that they're going to be, harmed themselves, or become victimized, terrorized in some ways. So I think it is really important for all of us doing this work to pay attention to the safety of the people that are going out, and the community response network can help with developing protocols around safety and finding out who are the partners. A lot of our remote communities, people will say, well, there's only me. I'm the nurse, I'm the social worker, I'm the community health rep, I'm it for my community. And so then who else is in that community that could come and do a visit with you if you needed to do that and wanted to make it safe? So those are all things that we need to think about. In the manual, there's lots of references and resources that you can go to for things like WorkSafe BC. There's guidebooks, handbooks for staff going into situations, conducting home visits and that sort of thing. There's some general tips on staying safe and ways of letting people know where you are, trying not to work alone if you can avoid it, knowing how to get out of the environment. So there's basic concrete tips that some of the staff might want to look at before they go out to a situation. One of the things that we often like to do is call the police. If there has been some reports of violence in the home, having a really good relationship with your local police department can help with the what do I need to know about before I go out to this house? We've heard this person has a history of violence. Is there something that I should be worried about myself going out? And sometimes the police will say that they want to come along with us because it is an address that they've had so many calls on that they don't think it's safe to go alone. And in those kinds of situations, we have to brainstorm with our organizations, with the other people in our communities, around how do we get access to the vulnerable adult when the environment is unsafe for us to go into. And we're going to talk a little bit more about that afterwards. So just before we go on our break, I want to give some recognition, a little bit of airtime to this whole idea of privacy and confidentiality. I know that it's really hard sometimes to work in small communities where everybody knows everybody and everybody is related to everybody else. And sometimes the people that you're related to are also the suspected abusers. And sometimes those suspected abusers also are the people who hold the power in the community and maybe even employing you as the worker. So it can be very complicated and very challenging to work in communities where they're so interconnected and everybody knows that there's something going on for this vulnerable adult, but everybody's too afraid to say anything or do anything or feels too helpless to be able to do that. So there's issues about privacy and confidentiality. As I said, in the Adult Guardianship Act in British Columbia, which guides this work here, if a report is made to a designated agency under the Adult Guardianship Act that someone's experiencing abuse or neglect, we as a designated agency must keep that information confidential of who made the report. So I can't say that it was Ruth who phoned me to make this report. And when I go out to do the visit, the client themselves may say, who was it that called? I know it was my busybody's, daughter. She's always, been at her brother and, she's just ratting him out and they will make all kinds of guesses about who made the call. But I'm not going to be able to disclose to her that it was actually Ruth who called me. So we do maintain that confidentiality as much as possible. There's always the caveat on that if this does go to court or if our records are subpoenaed, that it may come out. But even in those situations where we have had the Privacy Commissioner of British Columbia say you have to release that information, we appealed it to protect the identity of the person who made the report, and we won that case. So we do have some precedents to say that we will do everything we can to protect the identity of the person who made the report. The other issue is that we collect a lot of information in the course of our investigations. If I'm meeting somebody and I'm talking to neighbors and friends and physicians and the bank manager or whoever else in the community I'm talking to, I have a responsibility to keep that information confidential. I need to keep it in a secure place and I need to not be sharing it with other people. So we have quite a heightened authority for collecting information, doing abuse and neglect investigations, but we also have a heightened responsibility to keep the information that we do collect private and confidential. So does that make sense for everybody? Because I know that's a really big issue, and I know even when I talk about this, some communities will still say, yeah, but everybody's going to know who said what. And that can happen, and I think we have to work within our communities to strategize how we make it everybody's responsibility so that the finger pointing doesn't happen anymore. And again, the more we do awareness raising, the more we break the silence about abuse of our elders and vulnerable adults, the less people are going to be thinking about, who brought shame to our community to tell and get that outsider to come in and do this investigation. And more, it's like accepted. We as a community do not tolerate treating our vulnerable adults this way. So it could have been any of us that made that call, because we all as a community believe in doing that. So that's one of the things that's so important about us talking about this issue. So it's 2:30. 2:32. How about we take a 15-minute break? You folks on your remote sites, everybody there, if those of you that are still awake, hopefully you have air in your rooms. Stretch your legs, grab yourself a glass of water or some food or something, and come back in 15 minutes. We'll see you soon. And same to you. You see a few less people at some of the tables, but that's okay. And a few people here had to leave, and they've passed on their regrets and wish they could stay for further discussion. But they have said that they're going to start looking at the manual a little bit more closely, and then start looking at this whole concept of community response networks. So, do we know if there's other people?
Hi, Amanda?
Yes.
Amanda?
Yes.
Can I ask a question first? When you show the next video, could you turn up the feed on your end? Because it was really hard for us to hear the conversation in the last video.
Oh, okay. Was that the one of Dr. Dr. Caliu and Colleen? Because I have a feeling that one was, I think that one's actually a quieter video actually in all of our tools, but I will do what I can. How about when I get the next video going, give me a thumbs up or a thumbs down if it's okay.
I appreciate it.
Thanks. Okay, here it is. I found the right tool. So are we all back, ready to go? Thumbs up, thumbs down. Those of you who aren't back can't give me a thumb. So what is that big red thing we just saw come onto the screen? What was it?
That bag of chips?
Oh, a bag of chips. Someone brought their snack in.
Sorry, it's a bag of corn chips.
Oh, it looks good.
Sorry.
Just make sure you're muted, otherwise all we'll hear is the crunching.
Yes, we are.
Okay. This room doesn't allow us to bring any food or drinks into it, so we're a little jealous. Okay, so I think what we're going to do is get back on. Does anybody else have any comments, questions, things they want to say? Challenges, anything you want to say at all to me before we move on? Yes?
Hi, can you hear me?
Yes, we can.
I just wanted to ask Christine Baker from Squamish, do you have anything in there on issues around hoarding?
No, but I'm glad you raised that, Christine, because we did a session on Friday as well, and that same question came up, and I know that hoarding is a very complicated, challenging issue that we all are faced with. And first of all, I just want to say I'm not the expert in hoarding.
No.
Sorry. So,
Is there any
in fact,
way...
I have a teenage boy who's starting to look to me like he's becoming a hoarder. So when you look at his bedroom, but I do think that there is definitely a need, and I do think it overlaps with this work because of the issues of safety and possible self-neglect and ways to intervene. So I think that we do need more work done in this area, and certainly our representative from First Nations Inuit Health Canada has heard this now a second time, Danielle over there. And I know that there are some task groups. I know there's one in Vancouver that the Vancouver City receives reports, and there's a combination effort and strategy with the city, the fire, the police, and the mental health staff with Vancouver Coastal Health, who form a task group to respond to hoarding issues. But I don't have, I can't pretend to be an expert, and we haven't addressed hoarding as a specific issue in this manual, except for in those situations we can apply the same process to if the adult who's hoarding is considered vulnerable and unable to seek support and assistance because of a condition that, it may be a mental illness, and the hoarding environment is making them unsafe, then we may be able to use some of the same processes and tools. And we have used the Adult Guardianship Act to intervene in hoarding situations, but we haven't addressed it as a separate issue to deal with. I think it could be another whole chapter. We have, as we go through the manual, you'll see that we have a special section on psychological abuse, physical, sexual abuse, financial abuse, self-neglect, and I think we could also have another whole chapter just on hoarding. But I think it could also be a whole book on its own. So we can sometimes apply the same principles and procedures.
I'm wondering if there's any, what you're talking about, could you email me some information, like somebody I could talk to about that?
The task group?
Yeah. Could I get that information emailed to me?
Yes. Could I get you, Christine, to email me to remind me? And I'm Amanda.Brown at Amanda.Brown at vch.ca. Or you can also, yes, or you can also get me through the ReAct website as well. If you send an email to the ReAct website, you can get me there. Melanie, do you have something you want to say about that?
Yeah, I have a little folder in my Outlook that has the hoarding information that I have from the North Shore. And I wouldn't say it will solve anybody's problems. I think it's a problem that we can't solve easily as a society, but the information I do have, I'd be happy to forward through if you email Amanda, and then I'll respond with that too.
Okay, thank you.
Thank you. Great networking. Thanks, Melanie. Okay, anything else before we move on to the CRNs? Okay, so chapter 7 in the manual starts talking about this whole concept of the community response networks as a movement, because this really is a societal movement that we're seeing, not unlike, making communities safer for children and addressing child abuse, making women safer by addressing domestic violence, intimate partner violence issues. We are now at a time in our development as a society where we're looking at issues related to safety of vulnerable adults and violence against adults and older adults. So the community response networks have mobilized throughout the country, and what we're learning more and more often, and from more and more research that is done in this area of work, is that people are saying, it's not the legislation, it's not you designated agencies, it's not even you social workers and nurses and people that make us safe. It's having a community around us that make us safe. And in order to have that community around you, you need to be connected to it, you need to know who the network is. And community response networks really do work
towards bringing communities together around this common issue. So as you move through the manual, you'll see that there's a video clip with April Struthers, who is still with us over in Seychelles. Hi, April. And Alison Leaney having a conversation about this whole notion of community response networks. But because we have two of the Community Response Network mentors with us today, what I'd like to do is I'll first call on Jane Osborne to share a little bit of information around some of the work that she's doing. And then after Jane's done, I'm going to give you the heads up, April, that I'd like to call on you to share some of the work that you're doing around the protocol development and the being least intrusive tool. So Jane Osborne, please, could you move a little bit more into the center of your room because you're on the outside, and share with us about the work you're doing with CRNs.
Always happy to talk about the work of CRNs, Amanda, so thanks for the opportunity. I guess here in the biggest thing I have learned over the years is that every community is completely and utterly different. In North Vancouver, where I started my work, we are a fairly large urban area with more service providers than I can possibly ever keep track of. We did organize ourselves into a community response network, and we found, though, that we couldn't just have an open table where we said, everybody who wants to come and join us at the table, because we couldn't really find a big enough table, and the scheduling nightmare would be beyond what I could imagine. So what we've done here on the North Shore is create a sort of a steering committee, and we also, though, have a network of agencies of there's about 40 different members now of the Community Response Network. What the steering committee does is links together police. We have 2 police agencies, victim services people, health. Melanie Parkinson is our member at our table. It links agencies that represent people with developmental disabilities. Community Living BC is there, as is the North Shore Disability Resource Centre, Canadian Mental Health. We have representatives from our 2 First Nations, from Squamish and from Tsleil-Waututh. And the responsibility of that table is to try and identify the gaps, the places where people are falling through, where we don't have the right linkages between different service providers, or maybe where we don't have a service at all. And from that work, we design projects, and we've had a couple of things come up recently. Out of our Community Response Network table and the kinds of issues we've been bringing forth, a Seniors at Housing Risk project started and is now run by one of our service providers who is also a member of the table, and that's about making sure that we can find safe places for people who might be fleeing abuse. It's also just about seniors at a stage of their life, having who may, for one reason or another, not have the finances they need to be able to find appropriate housing. So that's what the Community Response Network does. Our current project is around conflict in congregation situations, and we found that exists everywhere. It exists on reserve. It exists, throughout this the senior subsidized sector, and so the steering committee is working on that. But on a regular basis, we also do projects with our different members, not necessarily members who are at that core table. So it's really been about how do we stay linked together as a community. And I think one other comment I want to make is that we have this formal term called the Community Response Network, and we have an organization called BC Community Response Networks. Yet my observation is that these things are in existence and they pop up everywhere, and Squamish and Tsleil-Waututh Nations have a project called Community Engagement Hub, and that is a de facto community response network. And that has sprung up because of their need to do the same thing, to understand the services on there, and I encourage Sheila or Mitzi to leap in on this one, to coordinate services to address vulnerable at-risk adults in their community. And they're recognizing that we can't do that all by ourselves as well. So we have to be connected to the agencies around us, like health, like police, like victim services. So we have these sort of two parallel but connected community response networks here on the North Shore, working independently and together on some things. And it's just a phenomenal, I think, movement. And I'm looking forward to moving up towards, I was in Pemberton the other day, I'll be in Squamish, Pemberton, Whistler, and points further, working with the communities there and their existing networks to talk about how can we make sure that there is a community response, whether it's formally called that or not, that's working in these communities. The advantage of formally calling yourself a community response network is you can get some resources. You can get some funding to do some initiatives around prevention. That's over to you, Amanda.
Thank you very much, Jane. And Jane did give a nod to the British Columbia Association for Community Response Networks. And they now have been given endorsement and support, financial support from the provincial government to share the prevention of elder abuse work in the province. And so they've been given a little bit more funding to keep their organization going. So there are mentors like Jane who can work in local areas to support the local communities to organize themselves. And so there's new mentors all throughout the province. So if you'd like to go to the provincial association, they've got them all listed by area. So you can find out who to contact in your jurisdiction to get support for developing a community response network, or finding out if there is one already operating in your community and how to connect with them. They've also got lots of information on their websites around education, awareness activities. There's things like gatekeeper programs that they support, friends, neighbors, and I forget, Friends and Neighbors Project. I can't remember, I think there's another word to it. So they have lots of tools and supports there for communities just to use and to go ahead and start developing. So BC Association of Community Response Networks, where you're going to find that on your website. If you just Google that, you'll find them. And then what I'd like to do is put April Struthers on the spot over in Seychelles, who can share with us some of the other work that's going on specific to First Nations communities that she's leading. Hi, April.
Hi, Amanda, and thank you for this opportunity. I want to talk about three things. First of all, to point out how closely the Association for Community Response Networks and the individual networks and the designated agencies work together. So designated responders are always really key in terms of sitting on community response networks, but also over the last few years we've been involved in other projects that have grown out of really those relationships, and so it's enriched our work by sort of creating hybrid situations where designated agencies, where the association, and then where specific either funders at the federal level, like Danielle's FINIB situation, or where First Nations groups and communities have allied with us to do some joint work. And we're trying to work a lot at getting the balance right to understand how to be good partners and how to carry forward the best of what everybody has to offer, no matter what sort of side of the cultural divide that you might be on. But in respect to that, I have to say, certainly on Vancouver Island, where a lot of my work takes place, I've been honored to go into lots of communities to be invited in with the ReAct material, first of all with the provincial material, and then with this version of it that you're seeing. And that has led to all sorts of opportunities opening up, and to conversations that wouldn't have happened otherwise, and to people being curious and figuring out how to do things very locally, but also how to find out what's happened in other places. So it's been a really valuable experience, and partly because I got into communities I wouldn't have got into otherwise by carrying this information and having it received and used in a way that within communities in a way that made sense to each community. So that's the first piece. The second piece is that out of that, there were some needs that kind of arose, and one of them was around how it is that we do our best practice. What is the way of being, if we're working cross-culturally, that makes the most sense? And it's really how you behave interpersonally, how you show that you're trying to be respectful, and how you are guided within communities by the people there, the allies there, whether they are health workers, social workers, or leadership in the communities, or elders coordinators, elders themselves, whoever it is that kind of champions doing something about this issue. And one of the things that became obvious was there were some more tools needed. And so a social worker that I've worked with a lot in the north part of the island, Lindsay Neufeld, who's a home and community care social worker, and I have produced a tool called Being Least Intrusive. And it's based on the legislation and also on the way of working with community response networks and with our allies in the communities that we were going into. So this tool was developed jointly, has been tested jointly, and has been taken across Canada now to be tried out in lots of different situations to see if it's useful. It consists of some background and a bunch of questions that we can ask ourselves when we're trying to do cross-cultural work and do it in a way that's effective and doesn't back off from the hard, complex problems, but also that has us outsiders and us mainstream people paying attention to what we need to when we go into First Nations, Métis, Inuit, and other Aboriginal communities. And that's something, obviously, that Amanda's already spoken to in terms of being appropriate and in learning how to be appropriate. Now, this tool is available free on the National Initiative for the Care of the Elderly website. This tool has also worked its way into some other work that we've done around protocols. And the Public Guardian and Trustees Office commissioned me to write a template for how you would get an agreement going between health authorities and First Nations groups and communities about what they want to have happen, so there's no surprises on either the part of the health authority or once the health authority goes into the communities for what will happen. So that means figuring out what the process is, if there isn't one, and not just having the designated responders or the health authorities bring their process in and impress it on everybody else, but have a kind of a joint process well understood before there's a crisis in communities. Because as you know, these are really emotionally loaded and very complex situations that happen. Being prepared beforehand and having an agreement of who does what when, which is also what happens at the CRN table, is very helpful. So the Kwakiutl Tribal Council on the north end of the island and the Vancouver Island Health Authority now have a regional protocol in place about how things will happen. And there's also a provincial protocol that is available. And anybody can use these protocols or use the templates that have been developed. And I understand that some of the other tribal entities and health associations on the island are looking at how to develop those protocols. It's just a question of becoming more coordinated, understanding culturally each other much better, and being more effective and less intrusive in doing this kind of work. Thanks, Amanda.
Thank you, April. Does anybody have any questions for April or Jane around community response networks? One of the reasons why I noted NISCA and the Aboriginal Health Authority being here today is that I mentioned earlier that the legislation allows for the 5 regional health authorities, so it's Northern Health, Interior Health, Vancouver Island Health Authority, Fraser Health Authority, and Vancouver Coastal Health, are the agencies that are designated, the health agencies designated to have access to the tools in the legislation. I'm not sure what that relationship will look like or if it needs to change with Niska Health and the Aboriginal Health Authority. And so those folks that work in those communities, I'm not sure how your adult protection work is happening in your communities. And if you have a relationship with the health authority that is a designated agency in your area, if there are times when we actually have to become more intrusive to protect an adult. And the legislation is one of those things that we can work with a lot of the time without even knowing that we're working with the legislation, but there are certain times when we are becoming more intrusive where we do need to protect somebody either against the family's wishes because the family is the abuser, or against the own adult's wishes because they don't have any awareness or judgment or insight to know that or believe or agree with the interventions that we're doing. So in those situations, for example, I was mentioning I can go into Tsleil-Waututh and even though I'm not providing direct service there right now, we have that relationship, and all British Columbians should enjoy the same protection no matter where they live, whether they live on or off reserve, no matter which reserve they live on, if they are on a reserve, no matter which health authority is providing service or not providing service, the laws should still protect everybody in the same way. And so I don't have the answers for our partners that are in areas outside of where I work. And if you don't have the answers, then you might want to start asking yourselves about how this work is being done. And if you don't think it's being done, then that's a concern. If it's not being done because you don't have anybody who's vulnerable or experiencing harm, then that's great. That's something to celebrate. But I think our experience is that there's often somebody in the community who does need some extra support, and the community feels pretty unsure about how to go. So at this point, I would just like to tell you who my counterparts are in each of the health authorities in the province. I think it was really exciting that there's so many people here from outside of Vancouver Coastal Health jurisdiction. So for you folks who are here from the Cowichan Valley, or I think that's the only place in Vancouver Island, but was there some in Northern Ireland? Oh, where are they? What part of the island? South Island? Great. So my counterpart in Vancouver Island Health Authority is Matt Scott. So you can always call the health authority there and say, you want to connect with Matt Scott. Somebody's become unmuted. Okay, there you go. Thanks. My counterpart in Northern Health, who has responsibility and is considered the key contact for adult guardianship and adult protection issues in Northern Health, is Louise Holland. And for Interior Health Authority, the key contact for you is Linda Myers. For Fraser Health, it's Leanne Lange. And then I'm your go-to gal for Vancouver Coastal. Did I hit them all? I think I got the whole province. So I would invite you to connect with any of those folks if you want to talk more about the designated agency's role and ways to connect around doing adult protection work in your communities, if you don't already know those people. Okay, so that's really, I think, a really good overview of the Community Response Network. So what this first full half of the day has gone has been talking around some of the general issues that we need to be aware of, ways of working together, building relationships, and we haven't done that much talking about, direct response. So this next section of the manual, from starting at chapter 8, starts talking about the actual individual situations. And I'm also going to show you the two other dramatizations. So just when we get into looking at situations of abuse and neglect, I want to be open and upfront with you about the model that I follow in doing a psychosocial assessment and trying to determine where the best point of intervention is when we have somebody who's experiencing abuse. And rather than take it from the more feminist model of the control and violence continuum or wheel, I look at it from a model of it being dynamic and interactive, and that we really do have to consider a lot of the factors around the situation, around what's going on for the abuser, and what is going on for the abused adult. And in order for us as healthcare workers to intervene, and we have to understand really what is happening in the whole picture. We need to, as social service workers and healthcare workers, we need to be able to recognize the risk factors and the things that can contribute to an abusive situation. I need us to get away from blaming the abuser, from demonizing the person who's harming somebody all the time. Sometimes that person does need to be punished and they're bad guys and they should be treated that way. A lot of the times that's not the case. A lot of the times they're the product of their upbringing. They may be situations. Sometimes they don't even understand that they are being abusive towards somebody. So we have to be able to assess all of these factors in order for us to be able to figure out the best way of intervening. Because we know already that in domestic violence, what we've learned from domestic violence is that people find it very hard to leave the person who's abusing them. We know that about child abuse. Children will choose to be with their parents even if they're getting beaten up. We know that in spousal relationships, there's very complex dynamics, and many, many times people cannot or will not leave because they're too connected and intertwined with the person who's harming them. So think then what it would be like to tell an 80-year-old woman that we need to call the police on her 50-year-old son who's misusing a power of attorney and is yelling at her or is refusing to leave her home or is getting violent and breaking the furniture and scaring her. It's so hard already to extricate ourselves from violent and harmful and unhealthy relationships. When we're trying to separate an adult child from their parent or the parent from their adult child, that relationship is that more primal, much more primal, right? It's for all of us who are mothers or fathers or grandmothers, we know that our children are like the core of us. It's, you take my child away, you take a part of me away. And it's not that easy just to say, well, you need to toughen up and just don't give them any more money. Just don't let them, make them get a job, right? Kick them out, make them leave, right? It's not that easy to do that if you think that that means your daughter's going to be on the street and she might go to the sex trade industry to survive. Or she might return back to an abusive relationship herself, right? So there's so many things that keep us in our relationships, and there's a lot of things that we have to understand when we're trying to intervene. So I think it's just really important that we start our next chapters on individual responses by understanding that this is the way, the model that I work from, and this is the model that I've kind of developed our intervention based on this. And I've come here from, obviously being a social worker, but also from working for years with older adults who have experienced harm and violence on behalf of, at the hands of their family members. And from hearing their stories and what they told me was going to be helpful and not. And in fact, probably only once in 18 years of doing this work did an older adult ever actually voluntarily say to her child who was abusing her, "You're not welcome back in my home." So that's not necessarily an approach that's going to work with some of these older adults for a whole lot of reasons. This is just a really quick video clip. This is Chief Robert Joseph of the Squamish Nation. He supported and consulted us when we were doing this work, and he had something to say, and I want to honor him by letting you hear it.
I'm really happy that we're talking about elder abuse today. It's something that's very prevalent in our communities, and we don't recognize it. It's part of a big secret, it seems, that we're holding on to, and I think it's important to break the silence around elder abuse in our communities. And so it'd be important for us to understand where that originates from. Why are we being abusive to our elder people? And I think one of the perspectives around that is that our elders have lost their identity as elders. They've lost their sense of responsibility and role in mentoring and teaching and passing on knowledge. And as a result of that, our young people aren't being taught the values and principles that are really important to hold and embrace early in our lives, so that when we live out every day, we practice these values and principles. And it's somehow become a cyclical dispossession of the legacy of honor and respect that we should have for each other. And so we need a seismic shift in our attitude around elder abuse. We've got to confront it. And one of the ways I think that would be important to consider is in trying to determine what kind of catalyst would really trigger us to get serious about confronting elder abuse.
Was that volume better?
Yes, thank you.
Okay, I'll turn it down a little bit so I don't, get too much into your heads. Am I still okay? Hopefully. So Chief Joseph had some really good points, and he was really wonderful to work with on this project. As we go through this chapter, and things that I want us to be aware of as we're intervening in situations where there's suspected abuse, is that there's many things that a victim of abuse may or may not say to you, and there's things that can trigger us, risk factors that we need to be aware of as you're going about your everyday business with an elder. So be aware of things like injuries that haven't been reported or aren't explained very well or suspicious. If the person is isolated, that's the single biggest risk factor to experiencing abuse in children, in older adults, and vulnerable adults. If there is no family, nobody around them, nobody who's watching out for them, they are more likely to be the target of abuse. And abusers will isolate them away from everybody else too. All of a sudden you stop seeing them at their regular events, and we're going to see these things in the videos that we see. Sometimes people internalize the blame, can become suicidal themselves. Often our adults that we're working with present as really difficult, cranky, leave me alone, won't let you get close. They have so much shame or anger or resentment or feelings they just don't want anybody else to find out about it. Don't call my family, don't talk to me about it. I'm fine, leave me alone, it's none of your damn business. These are all the kinds of things that we will hear. And we have to be aware of all of the factors, and that just because someone's denying that they're experiencing abuse doesn't mean that they're not experiencing abuse. And so sometimes that's our job to collect that collateral information, and a large part of our assessment is this person being abused? People are suspecting it, but then, is it really happening? So that's a big part of the assessment. And then there's a lot of things about the abuser as well, some factors or some indicators that we need to be aware of. Often they deny that there's any problem. They can present as being, overly caring and overly involved so that you can never get a minute with the person alone, and they'll answer all the questions for you and they'll speak on behalf of that vulnerable adult. They can be absolutely charming. And one of the first things I learned in this business, and it was police that were telling me this, and I thought I was pretty astute, tough, young social worker, and they said, don't you ever think that you can out-con a con, right? You may think that looking them in the eye and telling them that, you're getting these things set in place to protect the person, he will always be one step ahead of you. And, if you don't think like a criminal, you're not going to be able to outsmart them. So that is very true, and we can get fooled by these people. A lot of the times people who are abusing a vulnerable adult will try to make the adult look more vulnerable and more incapable than they really are. Oh, they're crazy. Oh, they're delusional. They're saying things. I know, when they're on their medications or when they're drinking or when they're not eating or in the mornings or whatever, they say these things and it's not happening. And so they actually make the person look more ill and more vulnerable. So there's a section in the manual that talks about some of these things to be aware of. You get people that promise you, oh yeah, I'm going to get the home support team in, and I'm going to bring mom to the doctor every week, and I'm going to do all these things. I promise I'm going to do it. And then they just don't do it. They just say what you want to hear to get you out of their house, to get you out of their face. But then they're not ever going to follow through on it. And these are things that we need to chart and watch and document over time and keep going back and to see and address them and see if we can change the plan as we go through. So recognizing who's vulnerable in your community is really important. And if any of your elders, workers, social workers, activity aides, people who help with the staff or with the healthcare, or sometimes the drivers, I know some communities, they'll have a driver that takes people to their appointments, elders to their appointments. These are the people that need to be trained on this stuff. How to recognize the adults that are vulnerable in the first place and what makes them vulnerable, right? How is it that someone has never ever learned to be able to ask for help, and why not? And Dr. Kelly, who talked about that, right? About, this self-determination, and if she asked for help or if she said anything, that meant you would get beaten, in the history of some people. Or that, the norm is to never get change when you ask somebody to go and buy you your vitamins. So if that's the norm, how do you know you're being harmed, right? If that's all you know. So it's really important to have people working in your communities recognize vulnerability. So when we go through this, recognize, the whole process here is recognize the vulnerability, report it. Know who to report it to. Have your workers know that they need to bring it to somebody in your organization who will be able to help them figure out what to do. ReAct. Assess the situation. Make sure that the safety of all the people who are involved are looked after. Respond. Have your community response networks, other community coordinated responses, knowing who are the people to go to and what they will do if they get called around an individual case, right? Because you've got the community now. Now you know on individual cases what they're going to do if I call the restorative justice folks versus if I'm going to call the police, right? So you need to know who's going to do what, and then always reflect. And I think this is so important for all of us in our practice and all of us when we work in the community, is to look back and say, well, how did that go? Did that work? And so many times we find it frustrating as healthcare workers because we call everybody and everybody says, no, not my job, right? Not my mandate. We can't do that. It's not our thing. And healthcare workers spend more time on their phone trying to get someone who says, yeah, okay, I'll go do that. And that's I think why it's really important for us to reflect on these as a community and as organizations and as individual practitioners, right? If you've gone and you've done an intervention, you've gone and created a response with somebody, what was that like for you? Were you frightened? Were you triggered emotionally yourself? Did you feel that you had the right support? What was the response from the people that you actually had the conversations with? Did the person appreciate having someone call it abuse and say, we've got supports for you? Or did they react to that? What can you learn and how can you approach it differently next time? So I think this piece of work is really important. So the next sections of the chapter of the manual move to each chapter focusing on specific types of abuse, and they all follow the same formula, where we first talk about what the definitions are of the type of abuse that each chapter is looking at. And then it goes into, I'll just skip by the video for now, what the indicators of that type of abuse are. And so they're all listed in here. And again, we could spend a whole day on each chapter. And in fact, our curriculum that we have for training adult protection workers, we would have a 3.5-hour module on responding to physical and sexual abuse and investigating this type of abuse. Another 3.5-hour module on financial abuse. So then the chapter will then follow if the adult's capable, if you've done that flow chart and you've looked through it and you've determined that the adult is capable, and there's tools that you can connect on to help you assess the capability piece and decision-making piece of that adult, then you could follow this process. Always offer support and assistance. Talk to the adult. Refer them to the community agencies. Provide treatment if there's any injuries or counseling in the moment. Let them know that you're available if they do choose to talk to you later, if that moment in time wasn't the day they wanted to deal with it. Acknowledge that the adult has the right to live at risk and work with them on a safety plan. So we can't always get what we want to have happen working with somebody who's in a violent relationship, but all those things are powerful interventions, and never underestimate how important it is to a person who's experiencing harm to have somebody come and talk to them and call it what it is, witness maybe their pain, offer them supports, but they do have the right, capable adults have the right to say no. But then if the person is more vulnerable, there's a different process. You may want to do all those things we talked about, but allowing the person to refuse intervention when we know that that person's really unsafe and they're very vulnerable, we may have to go ahead and do some interventions anyhow. So this next section of the chapter will follow the responder process. So that lays it out there for you. It also helps the communities who are not a part of the designated agency know what the designated responder process will be. So if you call me, you know that I'm going to have to follow this protocol, these procedures. So there's often multiple agencies involved. How do we all work together and figure out who's doing who? In an organization as large as ours, we have multiple programs within our big one agency tripping over each other sometime. And knowing whether it's a mental health and addictions worker who's going to go out, or is it the hospital social worker who's going to do the conversation, and who's going to call the police, and who's going to talk to the elder, and who's going to talk, right? So we have all these different people even within one organization that we need to figure out who's doing what. When you get into the broader community, it's really important that we have these conversations. So that's a part of the process. Then there's all the questions like, who does this assessment? I'm a nurse. I don't have a whole lot of training in trying to determine, is that person a competent adult to make decisions, to make their financial decisions. So you need to be able to work with the organizations and agencies around who is the most appropriate person in this client's life to make that determination, right? Does that adult have the best relationship with her family physician? Or does she have a great relationship with the elder support worker? So how do we get in is often decided by who's in that person's life in the first place. What is their comfort level with having these conversations? Do we buddy with that person? Do we train that person how to do this assessment? So there's different ways of doing it, and it's going to be different for every client, every adult. The manual will walk you through some of the screening, some of the clinical screening interview questions. I'm not going to get into all of this today, but you can, if you are the type of person who's going to have to be the person who goes in and have this assessment and do this interview, it's great to arm yourself ahead of time with what are the questions that you need to ask this person, and how do you go about entering into a conversation with somebody about their relationship where we think they're experiencing some harm. There's also the conversations that we have to have with the suspected abuser. Often the suspected abuser is the caregiver or is a member of the family who is very much a big part of that person's life. Sometimes we can't even get in to see the client without being able to have a conversation with the suspected abuser. So there's some tools that you can get from the manual here. These, again, it references the NICE network. For assessing caregiver abuse, there's some screening tools just to help get the sort of index of suspicion. And then it moves you through some of the actual interventions and supports. So there's a lot of information embedded in this manual that I think staff can go to at different points. If I was going out to do an interview with somebody who I got a report from one of our communities and I needed to come out, I probably would grab the manual and go to the section of the manual that talks about the type of abuse that's being suspected. So if it's sexual abuse, I'd be going to this section and I would be kind of reminding myself of some of the things I want to make sure that I include in my interview with that person. So that's, okay, so I'll finish the chapter and then I'm going to go to John's story because it ties it all up into John's story. So then after you've done all of the assessing and figuring out what's going on, you have to develop a plan, right? You need to figure out what is it we're going to do to try to help this person. And again, developing the plan is done in conjunction with the adult because after all, it's their life that we're talking about. We can't just come up with a fancy dancy plan and then if you go and you present it to the person and they go, yeah, I'm not going to do that, it's not going to be that easy to implement. So we really do need to think of what will work in this situation to make the person safe, honor the way they want to live, create safety around them, and include the people that need to be included. And it may be that the plan is all about working with the suspected abuser to help them with their addictions problem or helping them to get a job or something, and it may have nothing to do with the victim of the abuse. So we need to figure out our plan, work with the right people around that, and then we also have to look at what are some of the legal tools that we could use to support us. So sometimes we need to go to these when we need to protect somebody, like financial tools where we can find a way to protect someone's finances so that on check day, the person who shows up to takes all the money away can't actually access that money. Sometimes it's around healthcare decisions. The person refuses to go to get treatment for, the hip that needs to be done. And because of that, they're in a lot of pain, and we need to get some substitute consent for providing health care. So there's a piece of legislation that can help us to do that. So there's also ways that health authorities as designated agencies can apply for restraining orders under the Adult Guardianship Act, if that's what we need to do. We know that it's really difficult for an adult to get a restraining order, to come forward and request a restraining order to keep somebody who they love away from their home. And sometimes they'll say, yeah, I know he needs to not come here anymore, but I can't do that. I can't go and get that. So the health authority in some circumstances could go and apply for a restraining order to protect the person. There's also, of course, the Criminal Code of Canada. A lot of types of abuse are criminal code offenses. So each section of this manual will talk about specific to this area, right? So we've got sexual exploitation of people with disabilities is a specific Criminal Code of Canada offense. Incest, criminal harassment, uttering threats, sexual assaults, and negligence can be a criminal code offense. Theft by person holding a power of attorney. So there are a lot of things that people access to gain control and to victimize somebody that we can actually call the police and get the police to say, you know, that needs to stop. Maybe they'll lay charges, maybe they won't. Again, working with the police and getting them into your community response network is really important so that you plan how and when you intervene with police. And then at the end of each of these next chapters, you're going to have a section on what do you do if you do all of that and the person still refuses our care plan. And how so many times this is the case. We can't always force it on people, and sometimes what we have to do is get to a point where we negotiate something that we can all live with, that we feel that the person is safe enough to allow them to continue to live at risk or in that abusive relationship, but there's enough safety so that we know they're not going to become homeless because they've given away all their money, or they're not going to, die because they've got, gangrenous legs that aren't being treated when we need to get them their healthcare treatment. I mean, there are times when it does become life and death and we have to intervene, and other times when we can say, well, you know what, we can probably manage this at home, but these are the conditions that you need to meet us halfway on. So that's the format of each of these chapters, and we're not going to have time to go through them all, but I just wanted to lay them out for you and then show you the other two videos about Mary and John, because it sums up pretty much all of the things that we're trying to say, and in much more succinct way and entertaining way than what I've been telling you. So we'll have a look at John's story, and then we'll go to Mary's story, and then we'll just finish up with talking a little bit about working with the police, if that's okay with all of you. Those of us that are still here, still able to hang in and watch this?
Now we are going to share with you two stories about an elder who needed help and protection from abuse. These stories are fictional and may be disturbing. They are meant for educational purposes to be used by mature adult learners. Any resemblance to real situations is entirely coincidental and not intentional. We are going to start with John's story. Things haven't been the same since his wife died. John recently had a stroke. He is on blood thinner medication, and he needs to be careful with his diet. He is also a residential school survivor.
Charlie, ever since you've been here to look after me, I've been thinking about our trips up north. Those were good times.
You want another drink, Dad?
Sure, why not? When do I take my next pills? I'm not supposed to be drinking much with these pills.
Who cares about pills? Take them whenever you think of it. As long as you take them, you'll be fine.
Give me those. Those are all I have left. Careful, Charlie. Take it easy, Charlie.
Whoa. Are you crying? Does it hurt, old man? I need more money. The 50 bucks you gave me yesterday hardly covered your drugs, let alone the groceries and stuff we need. If you don't want to go live in that old folks' home, you're going to have to give me enough here to stay with you. I can't live on nothing, you know.
There's no more money in this house.
Look, Just because you got sick doesn't mean I had to move in here with you. I want to take care of you, but I need money to do that. I'm gonna go play bingo. You're too drunk to go anywhere. I'll see you later.
Charlie, where's your dad tonight?
You know how it is. He wasn't feeling so good, so he just wanted to stay home and rest.
Maybe I'll have a chance of winning tonight, for a change. He's way too fast for me, you know? He always wins.
Yeah.
Oh, Charlie, don't hesitate to say anything. John wasn't at the bingo last night. Charlie said he isn't feeling so good. Can you please check in on him when you're out that way? Something doesn't feel right.
Probably nothing, but since I'm going out that way, I'll drop in.
The spice and so on. Therefore, we've got a belly, we've got a bit of thyme. We haven't got that.
Hi, Charlie. How's your dad doing? I hear he didn't feel well enough to go to bingo last night. I thought I should check up on you two, and I brought some soup.
Thanks. Nice of you to drop by. I wish I could ask you to stay, but Dad's resting.
Well, I should check in on him if he's not feeling well. He may need to see a doctor, you know.
No, not today. He needs his rest.
Are you sure, Charlie? It'll only take a minute.
Who's there, Charlie?
Charlie, what?
I said not now.
Hi, I'm calling to get your input and advice as our designated responder. There are some indicators that one of our community members is possibly being abused. An elder's family member recently moved in, and since then, the elder's not coming to the usual community activities. We're all worried.
Thanks for calling. I'm going to ask you a few questions about the situation. Are you comfortable coming to the elders' home to talk about it?
Well, when I dropped by to see how things were going, Charlie stopped me from visiting. He can be very intimidating and basically pushed me out of the door. It was upsetting and very unusual for that family. Something is wrong, however, I'm willing to try again.
You're right. It does sound like something's wrong, and I don't think you should go back there alone. Is there someone who the elder knows and trusts who can go with you, or a colleague that can go with you?
Yes, we have a man who coordinates restorative justice circles here. I believe he may agree to help me with seeing and checking in on John.
This may be about money. Do you know if he has a bank account or even uses a bank? Or if there's someone in the community who's helped him to manage his finances?
I think one of the other elders will know the answer to that. They do discuss banking and finances together, especially since the residential school monies started to come in.
That's a good idea. Does your band have a peacekeeper or Aboriginal policing?
No.
Then a restorative justice coordinator might be the best person available to assist you.
Yes, I agree. I will ask him to come with me next time. He knows the son.
That's a good idea. And find out if the elder feels safe. He may have some thoughts about how to deal with this. But if his health is in decline, he may not even realize he's being abused. If that's the case, just bring in some extra supports. And please let me know how it goes.
Okay. Thanks for the ideas. Bye. We're here today because we're concerned that John may not be receiving the full care that he needs. John, how do you feel about how things are going?
I don't want to complain about Charlie. He's doing his best. I guess I didn't look after him too good either. My parents were in residential school, and so was I. Our family has suffered because of that. I didn't know how to bring up children, neither did my dad. I tried to get better at it, but my health seems to be getting worse. I can't remember when to take my pills. I know I shouldn't be drinking, but sometimes I do when we're watching TV.
Charlie, how are you doing taking care of your father?
Well, at first I was okay with it, but now I guess I'm not sure. I do seem to get frustrated and angry, having to remember all the things he needs to take or do. It just seems like my life is not my own anymore.
Do you think it might be better if we find someone else to help take care of your father?
Well, I do love my dad. I need to get a job and quit drinking. It's probably better for somebody else to help him out.
How do you feel about someone helping you out?
As long as I could stay in my house, it would be good. I don't want to be a burden on anyone, though.
I'm sure we can make it work if we work together. You have a lot of family in the community, and there are health support workers through the healthcare center.
Okay, so that was John's story. And does anybody have anything they would like to say, comments about what you saw and how we tried to bring together the concepts that we've been talking about in the manual? Was it too easy? Could it go that way in your community? Well, I'm just going to, oh, sorry, did someone have something they want to say?
King Collis have something.
Okay, go ahead.
Yeah, the program we just watched, we kind of relate to that in our community. And just last month, we did have an incident in our community that neglect was the factor of losing an elder. And this program that you just showed us has opened the door wide for us, and it'll help our community focus a little more on our elders. And we need to get together, Nisga'a Valley Health with Kincolas. As you guys have mentioned earlier, that we have what blanket court. My interpretation of blanket court is it's pure neglect, and I don't agree with that the Royal Canadian Mounted Police are putting out enough to help the Aboriginal communities throughout the Northwest, where we're having a hard time trying to get information from them as to their investigation. And this program that you have has opened the door where all the incidents that occur throughout Aboriginal communities is a closet thing and closet issue. And the silence of abuse is out in the open now, where we can work on it together throughout the West Coast, not only Niskas, Tsimshians, Haidas, Seesaw, all those that are involved in this program. And we need to focus a lot more where we can start listening to our matriarchs, who the matriarchs are the strength, the power, our cultural, our tradition, our way of life. And we need to work on that and let our children know, as the elder chief had mentioned earlier, that the children are not listening to our way of life, our cultural, our style, our tradition, because we're so in a hurry to get the best iPad, iPods, cell phone to step out of the world, and we're forgetting our own way of life, our culture. And the video that you just showed has really opened eyes up for us, my brothers and sisters that are here, that you could see in their faces that the hurt that happened last month, it's there in our heart, and it's there, and it'll remain there until we get further help from our own nation. And we need to get off that fence of looking. Television is the eyes of the world. You need to see what's happening outside, but we're forgetting our lifestyle because we're so in a hurry to get into our cars and drive away from our community and get out to see what's happening outside. It's good to do that part, but we have to remember our cultural, our lifestyle is the most important. And every time we lose an elder, we lose the value of our tradition. We lose our legacy when we lose our elders. And the young people don't see that because they're so in a hurry to take that step outside the door without taking that shorter step that our elders have always told us to do. Walk slow, stand still, and listen, especially to the matriarchs in the Aboriginal communities in BC, Alberta, Saskatchewan, in Canada. And we need to get together a lot more. And your program, our program, will help the young people to open their eyes and close their mouths. I want to thank you on behalf of our community that you've taken the initiative to see that our canoe can only go one way and stay upright, where we don't lose anybody in the West Coast, whatever nation we belong. Niska Nation has a common goal that we always learn and strive out of and live by. And we're not reaching in far enough to learn from the common goal. And your program has helped us to see where we went wrong, and we'll have to sit down and evaluate our situation of our elders and the youth of Kincola. Thank you very much. I appreciate your listening.
Thank you so much for sharing. And first of all, I want to say I'm sorry for your loss in your community, and the words that you've shared with us certainly have meant a lot to me. And I do want to wish you all the best, and if there's anything that we can do or I can do personally to support your community as you work toward developing your responses in your community, I'd be happy to share in whatever way that I can.
One thing that I forgot to mention, the community can call it when we have somebody that falls down. Everybody in the community comes together. The Coast Guard, the Canadian Rangers, the Fire Brigade, the nurses, teachers, priests, we all get together to comfort each other. But we need that open dialogue of what you have and what you just mentioned and you are teaching us now to further better our community as Nisqats and Gingol members and the family that we live with. That's how we get together with our community when someone falls, and the churches, the Anglican Church and the Church Army gets together, the choir, everybody, all hands on deck when we have a situation in that matter. But your program will further it, and it'll help us. It gives us more dialogue of what we need to understand for our families to live a better life in Gingol here.
Thank you. Unless there's any objection from any of you, I think because we're at the point in our day where I think we are sharing stories, I think I would like to move straight to Mary's story as well, because it also brings in some of the elements that the elder was just sharing with us as well. So, and just one thing I have to tell you about the people who performed and acted in these stories. Just raise your hand. Do any of you recognize anybody that you've seen on the screens today? And I have to say, this just tells me how much heart people put into this project, because of many of the things that we've just heard being said, is people care and have hurt, and they want to give back to their communities and to their people, and they're saying this is important for us to get involved with. So they volunteered their time to act for us. And John, who you just saw, actually is a gentleman who did have some health concerns of his own, had experienced a stroke himself, so that labored speech wasn't acting. That was really how he talks because of the stroke that he had had. And Mary, who you're just about to meet, is John's wife in real life. And they really enjoyed being able to come out and participate in this project for different reasons. They each had their own personal stories around it. So I'll let you see Mary's story, and then we'll come back together and talk a bit more.
Now we are going to meet Mary. Mary is in her late 60s and has a very busy life. In spite of enduring arthritis, she remains to be very active in her community. But lately, her daughter has had some problems.
Mary, this is a social worker. I asked her to come and talk with you about what's been happening at home for you. What sort of medication have you been taking?
I don't know what it's called, but it takes away the pain from my back. That little one I take for my nerves, and then another I take for my sleep.
Mary, is it okay if I look in your purse for address and phone numbers? The social workers could call your family. They will be worried about you.
No, don't call my family. They don't need to know anything about this. I don't want to cause any trouble. Please just give me something for pain.
These are supposed to be prescription pills. They're over-the-counter generic pills. Mary, what happened to your prescription drugs?
Mom, did you get the prescription refill for another 6 months?
Yes, I did, but the doctor warned me I better not lose any more pills. I can't understand how they disappear like that. Look, we need to talk. The last time your boyfriend was here, he pushed me into the bedpost. It really caused a big bruise. I wish you would get rid of him. I worry about you, so does everybody else.
Here, let me put your pills in your pill case for you. Look, my life is my life. Don't worry about me. Look, if he comes here, tell him I went into town.
You're pathetic. What kind of mother are you? Where's your daughter? You owe me money. Here, sign this.
I don't owe you any money. This says that I'm giving you signing authority over my bank account. Why you?
Just sign this and everything will be okay.
I gotta go meet a friend. I am not signing any papers. Let go of me.
You ain't going nowhere.
You let go.
It looks like someone's changed the prescription medicine for over-the-counter painkillers.
I need something for the pain. Don't let anybody know I'm here.
She may lose consciousness. You better call her family.
What do you mean? She's in a lot of pain and she does look pretty scared. Wait a minute.
Power of attorney. This name's Sidney Knowles to be your decision maker. We better call him.
I think she means it when she says she wants this to be kept a secret. This might not have been an accident. With these injuries, she could have been assaulted. Hello, Mary. Could I talk to you for a minute?
Yes, of course.
I understand and respect that you value your privacy. I'm just concerned that if you go back to the same situation, your health and well-being will be in jeopardy. So anything you tell me will be strictly confidential.
Well, I don't want to go through another hip surgery and weeks of recovery in the hospital. My daughter and her boyfriend were stealing my pills, and he was mean. I'm still scared of him. I don't want him around me anymore. But my girl is with him.
Do you have anyone that you could go live with, or that could come live with you until things get better at the house with your daughter?
Well, I don't want to be anywhere near my daughter's boyfriend. I would rather go move where my sister lives in the Elders Lodge.
Well, I'd be happy to work with you to make that happen. It may take a bit of time to make the arrangements for you to move into the Elders Lodge, and you may have to go stay somewhere else first before we can get you a room there.
Okay. Is there anything we can do about my daughter's boyfriend? I'm scared of him since he pushed me, and I'm also scared for my daughter too.
I'm sure that must be a worry for you. Let's talk about what options there might be for both of you.
I thought about going to the police.
Although you're afraid of him, what he did to you is against the law. And if we don't do something about it now, it could get worse for your daughter or other people he comes into contact with. And if you go talk to the police, we can come with you.
Well, that makes me feel better. Thank you.
Hi, Mary. So this is your new home. How do you like it?
I really like it. I get to spend time with family and friends that I haven't seen in ages. And I realize I have more support in the community than I thought. I've been in touch with my daughter, and she finally broke up with her boyfriend. He's in jail now, too, for assaulting me. Thank goodness I didn't go back. Who knows what would have happened.
You're very wise for reporting it to the police and for assigning power of attorney to your nephew.
Oh, he is wonderful. He used to always check on me and my daughter since my husband died. But I didn't want to bother him because he's so busy with his work. And now, with you and the others, he has shown that there are people that want to help. You know, this is how our communities lived before, taking care of each other with love and respect.
Well, every situation is different, and it can be difficult to recognize abuse or to know what steps to take to respond. We hope that this presentation will assist you and your community to develop strong and clear ways to prevent and react effectively to abuse or potentially abusive situations in your community. Every province and territory has laws and services that address many situations involving our most vulnerable adults. There is room for you and everyone in every community to step forward to break the cycle of abuse. Break the silence and break the cycle.
Okay, so that was Mary's story. Does anybody have any things they would like to say, to discuss, comment? Just hold the button down while you're talking.
I would just like to know.
And you have to hold it while you're talking, yeah.
I would just like to know if the videos go along with the materials.
Yes, absolutely. So the videos, as you see, this stuff that I've been showing on the screen has just come from this little USB stick. So if you have the USB, and if you don't have one and you like one, I brought an extra one and I'm happy to give it to you. They're on there. And what you see when you open up the USB is you see something that looks like this, that talks about, yes, let me see, you want to make sure we've got them. You'll get these little folders on your USB stick, and one will say the manual. So this picture that I've been showing is not a PowerPoint slide. It is actually the manual, and those videos are embedded in the manual. So if you're looking at the manual online, like we've been doing, when you get to those sections where you've got that picture where it says click on video, I'll make it a little bit smaller so you can see the whole page. So that's just the picture you see when you're looking at the manual, and that's page 54 of the printed version. So if you print out the manual, you see something that looks like this, right? You'll see Mary's story all of a sudden in the middle of your printed version. If you're looking at the manual online, you'll see that, and then you just take your cursor and you click on the black box or on the little play button, and it just goes right into the video for you. And if you don't have, and this is for all of you folks too, if you don't have the printed version and you don't have the USB, which all of your communities should have, because they have been provided to you and they're very easy to copy. If you don't have them, you can go to my website, the one that's www.vchreact.ca, and the videos are right there, and you can download the manual as well, both the BC version and this new and improved national version. I don't use the BC version very much anymore because it's got all the same material in it, but this has additional material. So you don't lose anything by not using the BC version, but you gain stuff by using the national version. Any other questions around how the technology works and how you may use these in your communities? So that's why we made it as interactive as possible, and having all these different elements to it, is that you can customize the materials, all of the things in there. Like if you want to have an elders session and you want to be able to invite elders to a luncheon and maybe show the videos just to get people talking about it, you can use these posters that are in the manual that you can put your agency's logo on, and you could write on a big Sharpie, elders luncheon, come to whatever on Wednesday. And so there's materials that you can adapt. We haven't shown them all today because they're all in your manual, but there's brochures that you can adapt to your community's identity. These brochures are really handy little tools because you can write the names of the people who are involved in the work in your community right on them. Again, just if you have the USB or if you have the manual, you press print and you've got ready to go manuals or brochures, posters, flow charts, anything that you might be able to use or you might want to use. And you can put your own nation's logos on there. We're not saying, oh, it's all Vancouver Coastal Health or First Nations Inuit Health. So we wanted to give you as many things that you can adapt as easily as possible to start having these conversations in your communities.
Will each of the participants today get a manual with a USB?
I don't think so. Unfortunately, I don't think so. Like I said, you can just download one yourself, to download a hard copy of it yourself. And if your nation should have been sent one already, Danielle's going to answer that question. So you should already have one in your community. Not on. I think you have to hold it while you're talking. I think so. Okay. Do you want to come up here, Danielle? Yeah. Sorry, Danielle's just going to come up here because the mic's so quirky. That one's on.
That one's on? Oh, maybe that's why. Hi, everyone. Elizabeth Pierce is the regional coordinator for the First Nations and Inuit Home and Community Care Program in BC. 190 manuals were sent out to go through all the home care programs, and those would have been sent out either fall last year or early this year. So if you want to partner up with the home care programs out in your community, they should already have the manuals, and it would be a great start for your community response networks.
Okay, thank you.
SSHS then to that. Can I ask a question?
Absolutely.
The House on Women's Center has developed a elder abuse resource guide, and I'd like to put this information in that guide.
Awesome. Go ahead.
They also are doing a guide for First Nations Women's Network Resource Guide as well. Maybe we could put that in there as well.
Terrific.
They're just developing, they're finalizing it at the end of this month, beginning of next month, and then they want to disseminate it to the Sea to Sky First Nations, and that's Lower Stetlium Nations and Squamish.
Fabulous. Thanks for sharing that. See, this to me is the beauty of doing these kinds of events, because look at the networking that we can do where we're hearing about things that people are doing in other communities. And the wonder about technology is that we can link to each other's websites, we can share, cut and paste, and do all kinds of things to connect. So I would also like to invite you to let them know that I'd be interested in their work, and I'd be happy to post that on my website. The ReAct website gets a fair amount of traffic, and we found whenever I do my stats on it, I find that our First Nations ReAct pages get more traffic than any of the other pages on my website, and I'm not a specifically First Nations program. So I just find that really interesting, and I think that only speaks to how little is out there and available for other people. I kind of think if people are coming to my site looking for information, then it would have been the last place I would go to look, right? So I think that's I think the more that people are doing and talking and networking and putting their information out there in the public domain, the better for all of us. You have a comment?
Hello. Okay.
We have somebody here, and then we'll go to you.
Okay. I just want to share that the BC Association of Aboriginal Friendship Centres, we have an elder council within that association, and we developed a toolkit for elder abuse, and we've done some presentations in a number of friendship centres in the province, so maybe we can share that with you as well.
That's terrific, and I have heard about that project. They did that shortly after we completed this one, and we had some conversations around the same time as they were developing it. And again, I think it's just so rich. And for anybody who thinks that this is duplicating each other's work, it's not. Our tools are geared for a specific audience. The audience for the Aboriginal Friendship Centers toolkit is a different audience. So I think they're all very important pieces of work. And the fact that they are all interconnected is great. It builds on the wisdom. And you know what I just love is that there's not competition in this area, right? None of us are selling this information or making money off of it. We're putting it out there to be used and sharing very generously. Was there somebody in one of the communities that wanted to say something?
I just wanted to make a comment. One of, I believe it was Mary Lou, asked earlier if we would be getting the kits, the binders, and the USBs, and you had mentioned that they were distributed to all the health authorities except the Nisga'a, and but I don't think that would keep us from accessing the electronic copy that you mentioned, and also it wouldn't keep us from printing it out, so we can still have access to that. Is that correct?
Oh, absolutely, and I'm sorry if I was confusing with my comments about that. I think Nisga'a did get the Home and Community Care Program with Nisga'a. If they have a relationship with First Nations Inuit Health Canada, they would have gotten the tools and the USB. What my reference to earlier about Nisga'a being slightly different is under the BC legislation, the Adult Guardianship Act, the health authorities are the designated agencies, and so I've never really understood what it meant that Nisga'a has its own health authority, and now even more recently we have the Aboriginal Health Authority. I don't understand that relationship and what that means to the Adult Guardianship Act, but what I think it means is those health authorities could become designated agencies and have access to the legislative options in British Columbia if they wanted to do that. And they would need to work with the political leaders and I think the public guardian and trustee if they wanted to be designated as an agency. But as far as the tools and the manuals and community response networks, use away. You do have them. We think you do have them in your home and community care office already. You're welcome to use them from our website. There's nothing stopping you from using the tools that we're talking about here today. It was only that piece about the legislation that I don't know how that plays out in practice in your neighborhood.
Amanda, can you ask who's speaking and I'll follow up with Elizabeth Pierce.
Okay, and Danielle has just mentioned, if you can say your name for me about who was just speaking about that, and Danielle will ensure that Elizabeth Pierce connects with you to make sure that you have a copy.
Millie Percival?
Millie Percival? Thank you. We'll ask Elizabeth Pierce to follow up and make sure that your community has been sent the material, and if not, make sure that you get it. So it's 4:30, and I did say that we were going to try to get out, and I can see some of you trying to leave right now, sneak out without us. You can be excused if you want to go. Thanks for coming and hanging in with us. We appreciate it. The only other thing, two other things I just wanted to mention about this manual and some of the tools that are available into it is that there does have another chapter about working with the police. It is a short chapter, but I know that's a really important piece. And I know that the gentleman, the elder who was talking earlier, also talked about the concern about working with RCMP. And we haven't really talked a whole lot about how we partner with the police, but that's a very important piece of the work. So there is a little chapter about that. And then right at the end of the whole manual, we have a quiz. So depending on how you want to use the manual in your organization, you may actually want to have, say you're saying you've got a new healthcare worker and you want them to know this stuff, you may say, go grab the manual, go do it online, and you want some evidence that they have actually learned something or they actually have done it. They can take a quiz, and at the end of the quiz, it's only 20 questions and it's pretty easy. And at the end of the quiz, if you've had any mistakes, you can review it, find out which one you got wrong. And if you, and then you can retake the quiz. And once you get 100%, you will get prompted to put your name into a certificate, and you press print, and you will have a certificate printed with your name on it saying you have completed the ReAct curriculum. So if you're training staff or you're working with any of your volunteers or coordinating your communities, it's kind of a nice giveaway. Or if you're hosting an event, that you actually get something to acknowledge that you've spent the time doing this work. So please use any of the tools that are in the manual. Have your conversations with your community, with your leaders, with the people who care about this issue. Listen to your elders, share your wisdom, and use these manuals and these tools in whatever way you find them to be helpful for you. So I just want to thank you all for your attention and your participation, and a big thank you to the Aboriginal Health Initiatives Program for supporting this in partnership with the Learning Circle, UBC Learning Circle, is that right? I've got it wrong. And again, a special thanks to the First Nations Inuit Health Branch for supporting us in developing these materials in the first place. So thank you all.
Thank you.
Bye.
Bye.
Bye. Thanks for coming.
Bye.
Thank you, Amanda. That was great.
Thanks, Melanie.
Thanks, everyone.
Okay, see you later.
Thank you for everything, Cola. Very informative.